Okay. Okay, so okay. Nope, that's fine. Okay. Okay.
Try to do it this way.
Okay. Good morning.
Morning.
Okay. So as you can tell, we're having to revert back on some things, okay, due to more positives within our class, okay. So we're gonna have to make sure everybody does good hand washing, okay. Wear your mask when you're in the building. We're probably going to do something a little bit different this afternoon instead of doing our group sim, okay? Because I just need you guys to not spread the love, okay? I want all you guys to be able to be here in person, to be able to have actual interaction. I'm really expecting the college to probably go ahead and change to a mask mandate since the actual school district here did, okay? So don't be surprised when you see everybody wearing masks again, okay? So we are gonna do traditional lecture this morning instead of what I had planned on doing, just because I don't want you in groups and pods again, okay? I wanna we're gonna get away from that for a couple weeks, just so we can see if we can keep people healthy. The other thing is a lot of you do work in healthcare, okay, already. And so you're already being exposed where you work. So just make sure that, you know, when you're on the floor, if you're an aide, you work in the COVID unit, make sure you're wearing your N95, take your clothes off as soon as you get home, take a shower. Don't wear those shoes anywhere else except just when you're at the hospital. I would even change before you get in your car, okay? Yes, Omicron is not as bad. Symptoms seem to be less for people, but there still are people that are highly susceptible to it that can end up in the hospital, okay? And so we just want to help in a way that we can just by preventing the spread as much as possible, okay? And so that's why we're back to masks. We're going to try to prevent it within here because we've had more exposure on our campus and seems like more within our little pod, okay? And so I just want to make sure that we're staying healthy, okay? Okie dokie. Everybody on board? Okay. That being said, where you're sitting today is where you're going to be for the next 2 weeks. I don't need anybody else moving, okay? Because I need to know if you're exposed. I have to know who's sitting around you so I can let the COVID team know and they can contact those people, okay? So I'm going to put it in the seating chart before we go to break here in a minute. And so where you are today is where you're going to stay for a while, okay? Okay. So the other thing is unrelated to COVID. So we have, I got an email yesterday from the library. If you go to print your PowerPoint, please do not print single slides. Please use the black and white. So when you're doing the print, you can choose if you're going to do grayscale, if it's going to be color, grayscale, or black and white. Choose black and white, okay? And do like at least 3 slides with the notes per page, okay?
I find the black and white won't show all the fonts.
Okay, I'll try to make sure that it's set to black when I set my PowerPoint, but because they're going through so much toner because we're all going over and printing, which you should be able to because that's part of your tuition, you pay for that. But we just need to try to help them out by reducing that. So I will try to make sure that my fonts are all in black. So that way if you do black and white, it'll be black and white, okay? Okay, perfect. Does everybody like my t-shirt?
Yes, I like it.
Oh,
Gave it to you.
I bought it. So I love to thrift shop, okay? Like one of my favorite things in the world. Like the thrill of going in somewhere and finding something really neat or really old and for really cheap. And so I was at Goodwill last year looking at t-shirts because, you know, people give their good stuff away. And I'm like, why would I pay full price if I can pay just a couple bucks for it, you know? And I found this and I was like, oh my gosh, that's perfect for me. So never gonna be this way ever again. Thank the Lord. But I can wear a t-shirt that looks like I am. Okay. So we're gonna talk about high-risk newborns today. Okay. So again, this is stuff that really can't fit into like a body system. Okay. So we're gonna have to just break this down for the newborn itself. So think of these things. Most of these things we're gonna talk about today, you're only gonna see in that brand new baby. Okay. So your student learning outcomes. So when we come to the test, the main things I will point out the main things I want you to remember, because these are things as a nurse outside of OB you possibly would see if you were like in the ER setting, okay? Or say you were a med-surg nurse and you floated over and are helping postpartum newborn moms, okay? So these are things you might potentially see. Those are the things we're going to look at, okay? So like always, I'm going to point you in the direction you need to go, okay? So for pregnancy risk factors, some things that we look at that could potentially make a pregnancy and then that newborn high risk: low socioeconomic levels due to poor diet. They have low income, therefore their diet is probably going to be more processed foods than fresh foods. Maybe limited access to healthcare, prenatal care. Thankfully, in the United States, most people, if they fall under a certain category or amount of money per year that they make, qualify for like an emergency Medicaid while they're pregnant. It may not cover anything outside of pregnancy related issues, but it will cover pregnancy and then the delivery of the baby and then cover baby, okay? But sometimes, unfortunately, we do have people that maybe don't fall low enough, but still don't have health insurance. And because of that, they may then either not seek health care or seek minimal health care related to their pregnancy. Pre-existing conditions can be an effect on baby and mom. Diabetes, any cardiac disease, hypertension, thyroid disorders, renal disease, anemia, exposure to environmental factors. Remember we talked about high altitude, why? Lower oxygen amounts, okay? There's not as much O2 in a higher altitude and they need more oxygen, therefore, they can't get it. Toxic chemicals potentially that they work with, and illicit drugs. Maternal factors are age and
For people
multi-parent.
that do live in the mountains, do they receive any type of, is there any medication they can get or anything?
The only thing is supplemental oxygen. I mean, that's pretty much all they could do. But of course, a lot of times it's those extreme high altitudes you're going to be looking at. And then too, if you look at, when you look at like the people group that lives like up near, what's the tallest mountain? Not Mount Everest, that mountain. No, the one that everybody climbs and dies on. Everest? Everest. Is it Mount Everest? Okay. So that people group, actually, people have studied because those men that help those people go up on the mountain, they don't use supplemental oxygen. And it's because their body has adjusted to the lower O2 levels. And so, I mean, they have babies and don't have complications. So there are some times that, nature takes over and helps. But if you have someone who maybe, even though we live at a higher altitude, if we were to move up to the Rockies, you may notice some difficulties in pregnancy because majority of your life you live here and your body hasn't adjusted to that higher altitude. But supplemental oxygen is probably pretty much the only thing they would do. So what are some pregnancy complications that we've kind of already talked about? We've got gestational diabetes, and we'll talk more about that during the endocrine system. Preeclampsia, hypertension, multiple gestation, which means multiple babies. 1 baby, 2 babies, 3 babies, 4 babies, 5 babies, 8 babies. That's an octomom. Abruptoplacenta, placenta previa, oligohydramnios, uterine ruptures, UTIs, rubella, herpes, CMV. You know what that is? Cytomegalovirus. Okay. Cytomegalovirus is one that if you as the mom get it, you're not going to have a lot of symptoms, but it does cross the placenta and can affect baby. Syphilis. Mom's pregnancy history. So if she has a history of stillbirth, she has a higher risk of having a second stillbirth. Okay. History of miscarriage. There's a higher risk of miscarry again because it's usually related to something physical with mom. You have a prior C-section, you're probably going to have a second C-section. Some people can VBAC, but it just depends on one, what the reason was you had the C-section, and 2, if your hospital allows it. And then RH sensitization. So we've got to look at neonatal mortality versus morbidity. Okay, so mortality is life or death, right? Morbidity are those things that then they have to live with for the rest of their life that could be detrimental to their physical health. Okay. So chance of death within the neonatal period, within that first 28 days is high. Okay, that's when you're going to see the biggest risk for a neonatal death is up to 28 days. 75% of all deaths occur in the first week. The highest chances within that first day. Risk to the neonate decreases as gestational age and birth weight increases. So the closer they are to term and the bigger the baby is, the higher the risk they are to survive. Or higher, the greater the chance, not higher the risk, greater the chance they are to survive. So the longer they cook, the better they are. Okay. So the morbidity risks, we have hypoglycemia, neonatal distress, congenital anomalies, and polycythemia. So what is neonatal distress? There's 2 types that we're going to talk about. One is respiratory distress. Okay, this is when a baby's going to have increased respiratory rate, retractions, nasal flaring, grunting. Does anybody know what grunting sounds like? Kind of like that. Okay, in between a breath or with that exhale. Okay. Excessive mucus. Okay, think again of those C-section babies. They didn't get that squeeze, so they're gonna have a little bit more fluid that we're dealing with. Gastrointestinal, we're gonna look at abdominal distension, projectile vomiting, bile stained emesis, and absence of meconium after 24 hours. Cardiac things we're gonna look at is central cyanosis. So remember we talk about acrocyanosis, which is the hands and the feet. But if we see central cyanosis, which is the main part of the body, that is not good. Okay, something's going on with that cardiac system. Urinary, if we go 24 hours without any urination, we've got to assess what's going on with baby. Jaundice, if jaundice occurs before the first 24 hours, that's a big deal. Okay, it's normal for most babies to start looking yellow after 24 hours, but if they look jaundice as soon as they're born or within that first 24 hours, it's a bigger deal. Temperature instability. This is a big one. Okay, you're an ER nurse. Husband runs to the door and says, "My wife is having a baby." You run out, the baby's sliding out, and it's 19 degrees outside. Okay. Your biggest concern at that moment, if baby's crying and thriving, is now I got to control this temperature. Okay, even though I'm just a few feet from the ER, any cold exposure this baby has increases that risk for cold stress. Okay, jitteriness, and the baby that has a glucose that's under 40. Okay. So what are some symptoms we'll see of a sick baby? We're going to see temperature instability, vomiting, poor feeding, lethargy, cyanosis, apnea. Okay, we're going to have to assess those stools. What do they look like? Are they having them? Are they having wet diapers? And is there any drainage? Are they having regurgitation? Are they having constant mucus coming up? So one of the babies we're going to see a lot is SGA, which means small for gestational age. Okay. IUGR, which is intrauterine growth restriction. Okay. So a baby that falls within that 10th to 90th percentile, an average weight baby, is going to be considered appropriate for gestational age. Okay. So if a baby falls within that norm, it's AGA. It's appropriate for the gestational age.
Anywhere between the 10th and the 90th?
Yep, anywhere between the 10th and 9th, which is a big range. But think about babies. You know, they vary in size and length based upon their gestational age. But if they fall below that, they're going to be pretty small or they're going to be pretty big. Okay. So small for gestational age, they're in that less than 10th percentile for their birth weight. So you're talking about like a 38, 39 week baby that comes out 5 pounds, 4 pounds, 11 ounces. Okay, even 5 pounds, 5.5 pounds close. Okay, you get there, you're close, 2,500 grams and below usually is about what we consider SGA if it's a term baby. Okay. Should be based on local population in which the infant is born. So if you have a baby that comes out that's smaller than you expect, it could be possibly preterm. Okay. But then you have to look at dating. Do we have good dating? If we have good dating and it's small, then it's not preterm. Okay. So then it's probably just either restricted growth, the IUGR, and that's probably what it is. Okay. Maybe it was undiagnosed in utero. But you're in a preterm, term, and postterm. So you can have this small for gestational age at any point, preterm, term, postterm. So again, it could be related to the IUGR, the intrauterine growth restriction. So they're undergrown. So we've got to look at this baby. Is this baby just small, or is it not fulfilling potential growth due to the condition? With these babies, it's difficult in differentiating between the fetus that is small and fulfilling its growth potential and a small fetus that is not fulfilling its growth potential. Because we also have to look at genetics, okay? So if we have 2 little bitty moms and dads, like our little Guatemalan couples, and that baby's short and small, it's probably not due to growth, it's just genetics, okay? So that's the other thing we also have to look at. Is it related to just genetics? So we have small mom and dad. small grandparents, look down the line. You can't just assume because it's little that it is due to growth restriction. But we also have to understand the pathophysiology of some diseases that we discussed, like our hypertension. What does that cause? Vasoconstriction or preeclampsia. And then we have restricted blood flow to the placenta, which then is going to be restricted blood flow to baby. So is it going to grow good? No. Okay. So if a mom has diabetes, so she can have constriction in those vessels, right? Vasoconstriction is a common thing in diabetes. If she has a heart condition, if she has hypertension, you just have to be aware if she has those conditions, she's possibly going to have an IUGR baby. Okay. Environmental factors, again, high altitude, maybe a mom who has excessive exercise. We also talked about moms who bind their bellies because they don't want to have a big tummy. Okay. That's going to restrict growth. Baby's not going to have enough room to grow. Could be related to work, maybe something they're exposed to, or even hyperthermia. Okay. So that's why they encourage moms not to use like hot tubs, saunas, things like that when they're pregnant. Again, placental factors that we talked about. This is going to be like your small placenta infarcts. So what are infarcts? Think about your heart when we say. So we talk about MI, so they have that infarct. What happens to the heart when it has an infarct? Stops, but what happens to the muscle itself?
It damages it.
It damages the muscle, right? And so does that part of the muscle usually live and continue? No, it kind of becomes like a scar tissue. So that you can have infarcts in the placenta. You can have part of the placenta that for whatever reason has a growth restriction and then calcifies or hardens, okay? You can have abnormal cord insertions, 2 vessel cords or previa. So along with this, I kind of skipped over the maternal factors. These can happen at any time. We've got the primipara, grand multipara. Okay, so it can be first baby, second baby, third baby, fourth baby, fifth baby. Okay, the number of babies really doesn't affect if you have IUGR. It's more so going to be related to either lack of prenatal care, okay, and those other maternal conditions like heart disease, diabetes, things like that. Okay. Fetal factors, so infection exposure. Torch, we already kind of talked about torch once. Anybody remember what torch stands for? Toxoplasmosis, which is, do you know? How are you exposed to toxoplasmosis? Cats. Have you ever heard that as a pregnant lady, you're not supposed to scoop the litter box? Okay, and that's fine. Because cats, if they are outside cats, will carry toxoplasmosis. You're also, if you are a gardener and you work outside in the garden, you're supposed to make sure you wear gloves and wash your hands well because you can also get toxoplasmosis from the dirt. Okay, so toxoplasmosis, other, okay, which can be other diseases, rubella, the cytomegalovirus, and herpes. These can cause congenital viral infections for baby because they cross the placenta. If a mom has syphilis, it can cause congenital malformations. Okay. So most frequent complications we're going to see is fetal hypoxia. And this is where they suffer from chronically lower than normal O2 levels in the uterus due to placental insufficiency. So our babies are small, they've got IUGR. We know that placenta is probably not functioning appropriately, so therefore they have a big chance of not having a good oxygen supply in utero. So when they're born, they're going to be hypoxic, and it's going to take more effort to get them to that normal level. So remember we talked about yesterday, a normal baby's O2 saturation at birth is what? 60%. So they're going to be like 40%. Okay, they're going to be lower than that 60.
Did you start giving them oxygen at that time?
Yeah. These babies are going to have some distress a lot of times. Not always, but a lot of times. They're at risk for aspiration syndrome. So hypoxia causes the fetus to gasp in utero, like as they're being delivered. Okay, so this results in the amniotic fluid being pulled down further. So that way when they kind of are trying to take that first breath, instead of air, they're pulling in fluid. Okay, yes, they already have fluid in the lungs, but it's pulling it deeper. Like, because remember, those alveoli are closed. So when they take that first gasp, they're starting to open up those alveoli. And now instead of air getting in there, what's getting in there? Fluid. Okay. It can also lead to relaxation of the sphincter and meconium passage, leading to aspiration of meconium in the uterus at birth. So if they have meconium that has passed, then they can aspirate that meconium deep into those alveoli, which would lead to possibly what? Possibly, but what's before death? Infection.
Is that when they have to, like,
Pneumonia.
drain the whole blood,
When they have to what?
clean the whole blood now?
No. So when they get meconium, it just is like it can cause bacteria growth in the lungs themselves, because it's an actual thing bacteria can sit on and grow on, just like if you aspirated anything else. And so that's why it could potentially cause the pneumonia. Okay. So pneumonia is your big factor when you have aspiration. Hypothermia. So these babies don't have a lot of sub-Q fat. They're little skinny, scrawny. They look like little old men. Like 90-year-old skinny, scrawny little men. Okay, they don't have a lot of sub-Q fat. So that depletion of the brown fat in utero, because it has to use that energy in utero, decreases the ability to conserve heat when they're born. So they're going to be at greater risk for hypothermia. Hypoglycemia. This is your most common with these little babies. It's due to that increased metabolic rate because of heat loss and poor glycogen stores in the liver. So they don't have that stored up brown fat. They don't have those glycogen stores. They're trying to metabolize to create heat. Okay. So that's going to make their blood sugar drop. And they're also going to be at risk for polycythemia. Red blood cells increase due to hypoxia. Okay. And then it leads to hypoglycemia. Because our body's trying to make more red blood cells. It's like, well, if we have more red blood cells, we can carry more oxygen, right? Well, if there's not enough oxygen to carry, it doesn't matter. Then they're going to have the polycythemia. So these kids can have a poor prognosis. Outcomes for a newborn with significant small for gestational age or IUGR, especially for before 37 weeks, can be dim. Okay. We can have congenital malformations with more severe IUGR. It means they're at greater risk for malformation. Intrauterine infection. So if they have exposure to rubella or the cytomegalovirus in utero, they are affected due to invasion to the brain and other organs due to the virus. Okay, so that virus actually attacks that baby's brain and organs, rubella and cytomegalovirus. These babies then continue to have growth difficulties post-delivery. And they, in the end, can have cognitive difficulties like learning disabilities, hyperactivity, short attention span, poor coordination, hearing loss, or speech defects. So as a nurse, if we have this SGA baby, what are we going to do? Okay, one, we're going to assess this baby. What kind of tool will I use to check for this gestational age? The new Ballard score we talked about yesterday. Okay, I can use that even though this baby may look preterm because it's teeny tiny. Does that mean it's preterm? No, it could be full term. Could be post-term. That's why I utilize that new Ballard score, because that's going to give me a better idea what gestational age this baby is. Okay. We need to look for signs and symptoms of other complications. So of course we're going to do a physical assessment. Do we have any other physical anomalies we can visually see? Okay. Are they compromised respiratory wise? Are they initially breathing? Okay. Are they trying to be vigorous and cry? Okay. We need to then remember the APGAR score. One of our first things, respirations and heart rate, right? If we have good heart rate, good respirations, because they're crying vigorously, then we can move on to the next thing. But if we have a limp, floppy, not crying baby, our initial is to get that baby to cry and breathe. Hypothermia again, remember they don't have the fat, so they're gonna get cold. Their blood sugar is gonna drop. And then in the long run, we're gonna be looking at feedings and weight gain. Okay, these babies are probably gonna be on a higher calorie formula. Okay, or if mom is breastfeeding, we may have to have her pump and use fortifier in the breast milk. We may have to mix fortifier with formula and use a supplemental system as she's nursing. That would then, as baby's nursing for mom, we're also providing a little bit of that formula with a higher calorie amount to help baby grow faster. Okay, doesn't mean baby has to automatically be not breastfed and formula fed. There's lots of ways to supplement the formula and still allow mom to breastfeed. So which is a priority for long-term follow-up with SGA babies? Okay, so if you have this NCLEX question on your NCLEX, let's look at that. So now we're thinking long-term, not immediate, not that first few hours and days, long-term, okay? So monitoring blood glucose levels. What do you think? Probably not. Initially, yes, but probably not long-term. Evaluation of growth patterns. That sounds like a good answer, okay? Referral to developmental experts. Maybe, we don't know yet, okay? Initially, is that gonna be our first concern in the first 6 months? No, okay? Follow up by the Student Nurses Association.
No.
Definitely.
Definitely not. Okay, so we're gonna look at those growth patterns. How is baby gaining weight? This baby is probably gonna have visits with the physician more often. They're gonna be being weighed and measured. How is the growth growing? Okay. As time goes on and they're growing better, those visits will be spread more. Okay. But initially they're probably going to be often because we need to make sure baby is growing. So these two babies are the same gestational age. Okay. They were both due at the same time. This is an average size newborn. This is what my daughter looked like when she was born. Okay. LGA, large for gestational age. I was 38 weeks. She weighed almost 9 pounds and looked like a sumo baby. Just like that. Okay. So these babies are in the greater than that 90th percentile. Okay. So what are some causes, some risk factors that could potentially cause a mom to have an LGA baby? Our initial and number one thing we know about is diabetes. Okay. Because mom has, if she has uncontrolled, those sugars are staying high, then baby's going to have a good supply of sugar and it's going to grow, grow, grow. Okay.
Is that like gestational diabetes or like mom has type 1, type 2?
Either one. Can be either way. If they're uncontrolled with either type, then you're going to have a big baby. Okay. Genetics again. Okay. So if you have, that's kind of why, you'll have your doctor ask you, what did you weigh when you were born, when you go in for your prenatal visit? Because we can kind of average weight based upon what mom or dad weighed. Now, not with me, because my mom was a smoker, was exposed to secondhand smoke. I was 41 weeks and weighed 5 pounds and 1 ounce. Okay. But that was due to IUGR. I had intrauterine growth restriction. So I was not the size I would have been if smoking had not been a factor. Okay. My husband weighed like 7, almost 8 pounds. Okay. So you look at genetics, you can kind of go by what mom and dad weigh. Okay. You've got dad, who's a football player, 6'5", 6'6", big muscular linebacker guy. Okay. Genetics can play a role and you can have a bigger baby. Okay, based on genes. Multipara. Why would multipara, do you think?
Because one might get more supplements than.
Nope, multipara is more than one pregnancy, not big.
Because the first pregnancy was not like an atomic one.
Mm-hmm.
And the other one.
Nope. What happens with every pregnancy? Your uterus gets bigger. It stretches more, right? So at that third pregnancy, is that uterus going to be able to stretch further than it is the first pregnancy?
No.
It is, because it's going to be, the first
more.
pregnancy, you're going to have a uterus that's it's only going to stretch a certain max volume. But with each one, because that uterus is more relaxed, it can grow bigger. So that baby's going to have more room to grow. Does that make sense? So that's if they're multi-para, this is not their first baby, that uterine muscle is more relaxed and it's gonna have a little bit more room to grow bigger. Okay,
So why is it that when you miscarriage, even though you get pregnant and then uterus grows? How come?
well, there's so many reasons for miscarriage. Okay, can be related to you have like factor V Leiden, which is a blood clotting disorder. Maybe you have a uterus that is odd shaped. Maybe you didn't have enough progesterone so it can contain that pregnancy. Maybe there was an anomaly with the baby, and really we do know that our body, if we it senses, it tells something's wrong, then it will get rid of the baby. There's so many reasons for miscarriage. And sometimes it can be if it's later on, like at 20 weeks or 19 weeks, it could be due to anomaly within that uterine cavity itself, maybe fibroids. Male babies, you guys tend to be bigger. Okay, common scientific proven factor. Baby boys tend to be bigger than baby girls. Erythroblastosis fetalis. Okay, have you ever heard of that? So it's not common, it's very rare. Okay, and it just causes the baby to have excess fluid, so it's going to be a bigger, heavier baby. Okay. Beckwith-Whittemire syndrome. Have you ever heard of that? Okay, it's a genetic condition associated with macroglossia, omphalocele, which is when we have the organs that are outside of the body inside that sac, and newborn hypoglycemia and hyperinsulinemia. Babies that have transposition of the great vessels. Do we know what that is? It's basically where everything's flip-flopped in the heart and the body with the vascular system. Okay. Complications for those LGA neonates. Birth trauma related to CPD. What's CPD? Cephalopelvic disproportion. Okay, so if we have a big baby trying to come out of a small pelvic inlet, we are at risk of having a baby that gets stuck. And we can have what's called a shoulder dystocia. The head can pass through, but remember our shoulders are the broadest point that then have to come through, and that shoulder can get stuck. Okay, so then a lot of times we have to do McRoberts maneuvers. We didn't talk really about this. We'll kind of talk about it on high risk day in a couple weeks with shoulder dystocia. So the nurse, you'll have a nurse on each side pushing the knees back almost to the mom's ears. You'll have one of the nurses or another nurse up on the bed pushing with their fist right above that pubic symphysis. And what they're trying to do is get that shoulder under. Okay, so you can actually fracture the arm and you can fracture the baby's clavicle when you do this. Okay, but if we caused a little bit of damage that can be fixed, that's better than having a dead baby, right? Okay. So these babies can have the risk for shoulder dystocia, which then can cause a fractured clavicle or humerus. Okay. These babies, when they're stuck like that, so they're halfway in, halfway out of the canal, then they're not able to get good circulation through that umbilical cord. So they're going to go through a little bit of asphyxia. They're not going to get that blood supply still running with the oxygen from mom. They can also suffer from facial paralysis due to nerve damage, skull fractures, cephalahematomas, and intracranial pressure or hydrocephalus. Okay, where they have the fluid build up around their brain. Okay. So intracranial hypertension, which is basically kind of like hydrocephalus, it's just a buildup of pressure and fluid around the brain. It usually resolves without shunting. Hydrocephalus, you usually have to have shunting. So these babies are going to be, you're going to have a bigger risk of having to have a cesarean birth related to that big baby, small pelvis. Maybe it's not even a small pelvis, it's a normal size pelvis, but it's a big baby. Okay. Doesn't matter how big that pelvis is, unless it's like an elephant pelvis, you're not going to get that baby through. Okay. These babies are a big risk for hypoglycemia, polycythemia, and hyperviscosity. So it's usually seen in babies of diabetic moms. You're gonna have that erythroblastosis fetalis or the other syndrome. So how are we gonna care for these babies? We're gonna monitor their vital signs. We're gonna assess for hypoglycemia. So with SGA and LGA babies, you're gonna follow your protocol for your facility for checking blood sugars, okay? At Southwest Med, we do one initially and then every hour, okay? Some places, they do one initially before the feed and then before every consecutive feed for however many, okay? Sometimes they do one before, one after the baby eats. Just depends on the policy for your facility. We're gonna screen for polycythemia. We're gonna make sure we do a very good assessment for that birth trauma, okay? We're gonna look at the skull, we're gonna feel the head. We're going to possibly even do x-rays, okay? Even if we don't feel anything, just because we need to double check and make sure we don't have any trauma to the brain or head or skull in the arm or shoulder. Assess for that facial paralysis. Okay, so when baby cries, just so when we do a stroke patient, what do? You know how to assess that they've had a stroke? Fast, right? So we're gonna look at their face. We're gonna have them smile. Well, can we tell a baby, can you smile for me? No, but they can cry, right? So when they cry, you're gonna see a difference. Yeah. Okay. We want to still encourage bonding, even if that baby has like a broken clavicle or a broken arm, and we have to like, you know, wrap them up, keep it in place. Still encourage that mom to hold that baby and bond with that baby. Sometimes they're scared too because they're afraid they're going to hurt them. But then we just come in, we show them how to pick them up the best way without causing too much concern for pain, and then let them know they're going to hurt a little bit, but once they get on you and they're laying, that it's going to go away. Okay, and a lot of times that's a better way to soothe that pain than anything else. Who's looking for their phone? That sounds like me all the time. My husband, I'll do it. He'll just look at me because usually it's like right here, or right in front of me or in my hand. And I'm like, where's my phone? I'm that person on the phone, like, where's my phone? Yes. Okay. And with those babies that have bruising. Okay, because if they had a difficult delivery coming out, they're going to have some facial bruising. Okay, it's going to happen. My daughter had facial bruising because she was so big. And so she looked purple in her first few pictures. It gets better as the day goes on and usually goes away by 24 to 48 hours. It's not like a long-term bruise. Okay. Complications of infants with diabetic moms. Okay, and this again can be type 1, type 2, or gestational. If mom is uncontrolled in any of those types, it doesn't matter, okay? So hypoglycemia, which is any blood sugar less than 40 for a baby. Usually you're going to see those signs and symptoms 1 to 3 hours post-delivery. So that glucose supply to the fetus for mom has been cut off, okay? It no longer is having that high amount of glucose to baby. So we know with these babies, mom's blood sugar's been high, been feeding that baby high blood sugar. So how is baby's body responding, do you think? What do we do? What do we create to reduce our sugar levels? Insulin. Our body creates insulin, right? To reduce the amount of sugar, to break it down. So you have this teeny tiny baby that's been getting this high amount of sugar. So what's its body doing? Creating more insulin, right? And it's going to have what's called hyperinsulinemia. It's going to have a high amount of insulin within its body. So now, its cord's been cut. We no longer have our sugar supply, but that baby already has this high amount of insulin within its body. What's it going to do? It's going to drop, right? It's going to have high amount of insulin, but now its sugar level's cut off. And you have all this extra insulin, it's going to cause that blood sugar to drop, okay? So with this hyperinsulinemia, how we try to prevent it, and we'll talk about this when we go through gestational diabetes and endo, is while mom is in labor, we're usually, if her blood sugar is above 120, she's going to be on an insulin drip. okay? And we're gonna give her insulin through the labor process. And what that does is it brings her blood sugar down to normal, which then would allow baby's blood sugar to come down to normal and reduce the amount of insulin its body is making. Okay, we're not sending the insulin to baby, we're giving it to mom to drop her blood sugar to then allow baby's blood sugar to drop and be normal and hopefully reduce the amount of insulin within its system. Okay,
What is the normal level?
well, we don't draw an insulin level most of the time. Main thing is if we know mom's blood sugar is normal and baby's blood sugar is normal, their insulin amount should be normal. Yeah, we usually don't draw a level for insulin. We just know if their blood sugars are normal, then their insulin levels should be normal. So what are we gonna do to treat these babies? We're gonna do monitoring of the blood glucose. So 1 hour every 4 hours, or 1 hour times 4. So Q hour times 4. Then if it's stable, a lot of times we will no longer check unless they have signs and symptoms. But they can also then continue it on every 4 hours. So if we have a baby that's in the nursery that's having to receive D10 because its blood sugars dropped because it did have some hyperinsulinemia post-delivery due to a diabetic mom, we're going to do those initial blood sugars, and as long as they're normal, then we still are going to continue every 4 hours. If baby's in the room with mom and stable and feeding well, we're probably going to discontinue them, okay? Unless we see signs and symptoms, which we'll talk about signs and symptoms of hypoglycemia here in a little bit. We want to encourage early feedings. These are those babies, if we can get them on that breast within that golden hour or start the formula, if that's mom's choice of what she wants to eat. Why wouldn't we give just sugar water?
Because it drops their sugar after.
Right, used to we did. Their initial feeding would be sugar water, but we don't have any added protein. We don't have anything else in there to help maintain that blood sugar long term. So we're going to spike that blood sugar and then boom, it's going to come back down. Okay. So now we know over time of studying that we don't want to do the sugar water. We're going to go ahead and do something with protein, breast milk formula. If they do have to have an IV, then they're going to usually be started on D10W. Okay. And it's going to be 6 to 8 milligrams per kilogram per minute. Okay. Not just for fun. I just started doing IV amounts by weight.
No, on pharmacology?
In farm. Okay. Okay. Let's just think about this. Okay. And make y'all use your brain this morning. So we have a baby that weighs 4,400 grams. How many kilograms is that?
4.4.
Okay. 4.4 kilograms. Okay. So let's say the doctor says I need 6 milligrams per kilogram per minute. Okay. So I'm going to multiply times 6, right? So somebody multiply that for me. So 26.4 milligrams per minute. So how many milligrams am I going to have in an hour?
26.4.
Times 60, which is
1,584.
1,500.
84. That's 24.
Okay. So this is our hourly amount. Okay, so I'm not going to break it down to where we do mLs per hour yet. I don't want to confuse you too much. Okay. But do you see how we did the math there? Okay. I do not do dimensional analysis. Okay. The reason is because it confuses me. My old brain doesn't work that way. I learned this way. This is how I learned, which basically is the same thing as dimensional analysis, but instead of making one super long math problem, we're just breaking it step by step. Okay. So here pretty soon, guys will start doing your IV calculations, okay? Huh?
So will you just teach me that way instead?
Yes, I can. You wanna know, can find me sometime. Okay. So what other complications can be related to a baby that has diabetes, or a mom that has diabetes and that baby? They could have hypocalcemia. Okay, what does calcium do in our body? Okay, bone and heart. How does it regulate the heart? Yes, but it works with our muscles, right? We gotta have calcium for our muscles and bones to work, right? Okay. So it can cause tremors. Usually you rarely have to actually treat these babies because we're gonna have that increased calcium with their formula. Hyperbilirubemia. Okay, so this is a baby that's gonna get jaundice, but they are LGA, they're at bigger risk of jaundice because of the bilirubin, which is related to what? Red blood cells, the polycythemia, okay? They have too many RBCs, so therefore they're at bigger risk of having jaundice or hyperbilirubemia, okay? Birth trauma, too big. Polycythemia, so they're gonna have excess red blood cells production due to hypoxia. The body's gonna make more because they're gonna be hypoxic as they're delivering or prior to. Respiratory distress. We're gonna have tachypnea, which is fast breathing. They're gonna breathe faster than 60 respirations per minute. Grunting, retractions. What is a retraction?
Where they sink in their stomach.
Right. You can see it below the rib cage. Okay, you can have intercostal, which is between the ribs itself, or clavicle. Okay, you're gonna see that tissue pull in. Okay. Possible some congenital birth defects, and this could be related to the diabetes, okay, with mom, so they can have some GI problems, skeletal problems, or cardiac malformations. So what are we gonna do for these big babies if it's not mature? And just because it's a big baby, does that mean it's a mature baby? No, think about, have you ever heard of someone having a 35, 36 week year that weighs 6, 7 pounds? That's probably an LGA baby due to the fact that it should not be that way at 36, 37 weeks. If dating was right on spot, we know that mom was exactly that. And now we have this big baby, okay? So it doesn't necessarily mean they're mature. So we're gonna have some respiratory distress, hyperbilirubemia, birth trauma, congenital anomalies. We're gonna have to monitor blood sugar. We're gonna check a hematocrit for polycythemia. And we're gonna educate mom on baby's health needs, okay? Because mom's tired. We're gonna have to educate it how important it is to really wake this baby up and eat every 2 to 3 hours, okay? If they're breastfeeding, every 2 hours. If they're formula feeding, at least every 3 to 4 hours, okay? So they have to wake that baby up and feed it, because otherwise, until they're stable, that blood sugar could possibly potentially drop. So how often should a blood glucose level be done on a baby that's mom is diabetic?
Every hour for 4 hours.
Every hour for 4 hours, and then if they're not stable, every 4 hours for 48 hours. Remember, you got lots of fours there, okay? Every hour times 4, then every 4 times 48. What blood glucose level should interventions be performed?
Below 60.
Below 40.
Below 40, okay? So if we have a mom, we go and check a glucose on a baby, and it's 41. Do you think we should probably initiate some interventions?
Yeah.
Probably. It's still good, it's within range, okay, but we're gonna say, hey, you know, when was the last time baby ate? Oh, it's been 3 hours. Well, we probably should go ahead and eat. Encourage the baby to eat. So let's get this baby, it's all wrapped up, nice and warm, and we put it to breast. Is it gonna wanna eat? What do we need to do? Uncover it, unwrap it, undress it, get it down to the diaper, make it agitated, change its diaper, okay? A lot of times these moms don't know that they need to wake baby up that way. They're just like, oh, well, they should be hungry. We're just gonna take them bundled up and put them to breast. Well, baby's gonna be nice and cozy and warm, and they're gonna get right to mom's breast, maybe suck a couple times, so what are they gonna do? Go back to sleep, okay? So we need to then show them, unwrap the baby, show them, take the clothes off, change the diaper. I even sometimes if I have a baby that's really kind of super sleepy because their blood sugar is a little lower, then I may even get like a wet wipe and kind of take it and swing it in the air a little bit, cool it off, and rub it down its back. And it really wakes up. Okay. I know it sounds mean, but what do we need? We need that baby to eat. Okay. We need to agitate that baby enough to wake up to eat. Okay. So what are our interventions? Feed the baby. Okay. So if I have a baby that has a blood sugar at 35, I'm going to initiate feeding. Okay. Then I'm going to reassess when. In an hour. Okay. We can reassess a little sooner if we think we see signs and symptoms, but really you're not going to see the metabolism of it until close to an hour. Okay. If it's below that and you have other symptoms, if you have respirations above 70, we're usually not going to go ahead and feed the baby with a bottle or on the breast, because what's our risk? Aspiration. Okay. So that baby may have to have an OG tube fed. Okay. Or we may have to initiate an IV and start D10. Okay. Post-term babies. Okay. These little guys, they're always coming out wrinkled and peely. Okay. So after 42 weeks is post-term. Okay. We could maybe have an inaccurate estimated birthday or estimated due date. Okay, if you have a baby that comes out looking like this and they're supposed to have been 38, 40 weeks, no, this baby's 42 weeks. Okay. So normal weight for a baby that's post-term can be 4,000 grams. Okay. Complications related to this is going to be post-maturity syndrome. With this, you're going to see hypoglycemia, because they're going to have depleted glycogen stores. Because after 40 weeks, that placenta is going to kind of start to be like, hey, I'm done. Okay. It's going to stop working as well. So then baby's not going to have as much nutrition from mom. So it's got to use its own storage to then maintain. Okay. But then sometimes you have a placenta that keeps on working and that baby just keeps on growing and you have a 4,600 gram baby. Okay. Meconium aspiration. These babies that are post-mature, bigger risk for having passed that first stool, so they can aspirate that fluid with the meconium. Polycythemia due to hypoxia, again, because that placenta is not working as well. We're not getting enough oxygen supply. So the baby's body's like, hey, I need more red blood cells. Hey, I'm not getting enough oxygen, maybe I just need more red blood cells. So it makes more red blood cells. That's not going to help because we're really not getting any more oxygen. So it's going to have the polycythemia, which could lead to what? Just talked about it. Jaundice. Okay. Hyperbilirubinemia. Do you think jaundice is something important to know?
Yeah.
That's going to be one of the most common things you're going to see post-delivery. So yes. Okay. Congenital anomalies, seizure activity from hypoxia, cold stress, because sometimes if they're not growing and they're having to use those glycogen stores, they're using their own body fat to burn to have energy. So these babies are going to be those little, sometimes skinny, scrawny old men, long and thin. So the post-term infant begins losing weight but has a normal length and head circumference. Okay, it's a combination of advanced gestational age, placental aging, decreased placental function, and continued exposure to that amniotic fluid. Because remember that vernix has now disappeared. So we don't have that protection on that skin. Morbidity and mortality is 2 to 3 times more than a term baby. Okay, you get to 42 weeks or greater, your rate of stillbirth goes up. Death may occur during labor due to fetal distress, using unnecessary body reserves in utero, or just due to the placenta no longer functioning and it's not getting what it needs, okay? Decreased nutrition and oxygen, okay, so they're gonna have hypoglycemia, hypoxemia with labor, and then at delivery, meconium aspiration, polycythemia. These babies a lot of time are gonna have oligo, they're not gonna have enough fluid. So these are the ones we talked about having that thick meconium, so they pooped. There's not a lot of fluid to thin out the poop. So what's gonna happen? You're gonna have a very thick meconium around these kiddos, okay? So is that gonna be easy to clear from the mouth and suction? Not as easy as just thin watery stuff, okay? So they're at a bigger risk of aspirating meconium. Congenital anomalies, and again, with these congenital anomalies, sometimes we don't know what causes them, but it could be related to why baby never delivered like it was supposed to on term, okay? Seizures, cold stress. So we're gonna look at this baby. You're gonna see dry, cracking, peeling skin, long fingernails. There's gonna be no vernix or lanugo left. A lot of times they'll be stained from the meconium. And the most common place you're gonna see this is the umbilical cord. Okay, so even though after the baby's been born, it's been a couple hours, got a bath, that little umbilical cord still attached will be kind of tinted green, especially if they were in that meconium for a long period of time. The baby's body is usually long and thin with that sub-Q tissue depleted. So what problems are you assessing for? What are we gonna look at?
The aspiration.
Right. So remember how we talking about in adults, we do our ABCs, airway, breathing, circulation. With a baby, you add your T, okay? Airway, breathing, circulation, thermoregulation, okay? Always add your T because of these newborns, temperature is very important. They can have hypothermia, hypoxia, respiratory distress, hypoglycemia.
Maybe more at risk for respiratory distress, not because of skin of their lungs not being mature enough, but because of that aspiration risk.
Yes, yes, because especially if you have meconium, they're gonna be at a bigger risk for respiratory distress. And plus two, their reserves are depleted. So when they come out, they're less vigorous because they've kind of used all their energy supply. And so when they come out, they're not gonna be one who's wanna be real lusty crying. They're gonna just kind of be there flaccid. You're gonna have to do a lot of effort to get them to sometimes react. So treatment and care for these babies. So antenatal testing, we need to make sure we evaluate the fetal status. So what do you think antenatal testing would be
Before they're born.
before they're born? So what kind of tests could we do there at the end of pregnancy to kind of see how baby's doing? Biophysical profile. Okay, we're gonna look to see, does that baby, what's their weight? Is that placenta having good blood flow? Do you see good blood flow through the cord? Do you see respiratory effort on baby's part? How much fluid is around that baby?
Around
Okay.
how many weeks?
Well, if they get to 41 and plus, they're gonna do biophysical profile every week. Okay, what else? Non-stress test, yep. We're gonna put that mom on the bed, we're gonna put a monitor on her, we're gonna look at, is she contracting? How's baby reacting to those contractions? How is just baby reacting to being in utero right now, okay? Amnio infusions, we kind of talked about this with that IUPC that we can put in to measure the pressure of those contractions. We can actually put fluid through that and infuse fluid around the baby, okay? We don't do it as much anymore just because usually, you know, at that point, if baby's stressed and we're having to do an intervention like that, the best action is probably just to deliver via C-section. Of course, if you talk to mom and the mom wants to try other options before we do a C-section, then this is something a doctor could do, is do an amnio infusion where we put the IUPC in, flush out the uterus with some LR, warmed LR, and you're gonna do it via pump, okay? You're gonna put in fluid, and then you're also going to have to measure the output of fluid. So all those pads that come out wet, we've got to weigh. Okay, and how do we know how much it weighs?
You
You weigh it with a
dry
scale.
one and then a wet one.
We do a dry one and a wet one, and so how do I know how much it weighs?
1 ml.
1 gram is 1 ml. So if I have 500 grams, I know 500 mLs of fluid have come back out. And then I need to see how much fluid had I put in, okay? We're gonna monitor for hypoglycemia. We're gonna initiate early feedings, IV glucose if needed. We're gonna make sure these babies stay nice and warm. And we may have to do some oxygen supplementation for respiratory distress, okay? Okay, let's take a 20-minute break. 9:31, so at 9:51, we'll be back. We'll talk about the preterm infants.
Hey, Amanda.
Yes, ma'am. Yes, ma'am.
Oh, sorry, I hit mute again.
Yep,
I
you're
didn't get
fine.
an email about the assignment for yesterday.
Yes, I was gonna do it last night, but guess what? I fell asleep.
Okay,
So when I go to my office right now, I have it made up. I just have to finish, do a few touches to it, and I will email it to you, okay?
thank you.
You're welcome, hon. Bye. Snow tonight.
Where I saw drizzle on the
Mhm.
way out of here.
Yeah, we get snow flurries off and on. So. Okie dokie. Now we're gonna talk about little babies, preterm infants, okay? So this is anything after 20 weeks and before the end of the 37th week, okay? Again, 37 to 39 is still considered term, but we try not to deliver at that period of time because we do know that we have an increased risk. We're not going to electively deliver it unless we have a reason. Okay, they go into labor on their own. We're not going to stop it at 37 weeks, but we're not going to induce or do a C-section unless we have a reason. So complications of these babies: cardiovascular and respiratory system. We can have problems within both. So they're at the bigger risk of respiratory distress. What are we missing in these babies?
Not fully developed yet.
Their lungs aren't fully developed. They don't have what? Surfactant. Okay, I know it's on the screen, but I was hoping for me to read it. Surfactant. So does anybody remember what medication we talked about we would give to mom?
Cervanta.
No, that's what we're gonna give to baby. Betamethasone. Betamethasone is what we're gonna give, okay? We're gonna give it to mom, she gets 1 dose. 24 hours later, she gets the second dose. And we want to delay delivery at least 12 to 24 hours after that second dose if possible. Betamethasone. It's a steroid. And we're giving it to mom, but it goes through the placenta to baby and triggers the release of surfactant. Okay. So their pulmonary systems aren't able to take in and exchange gas until about that 37 to 38 week, because that's when their body releases that surfactant, creates it. They have incomplete development of the muscularity of the pulmonary blood vessels. And they tend to keep that ductus arteriosus open. Okay, kind of just stays open. They have a greater risk of it not closing. When that ductus arteriosus doesn't close, it increases the backflow back into the lungs. Okay. So they're at a bigger risk of having pulmonary congestion, which increases their respiratory effort, their CO2 retention, and causes them to have bounding pulses. Thermoregulation problems we're going to see. They lose heat faster than a normal sized baby. Okay, and the reason is because remember, they are more flaccid, they're gonna be spread out, which causes more body surface area. So the baby is more bent in on itself, that reduces the body surface area and causes the heat to be retained. So loss of heat in the preterm infant of 1,500 grams is 5 times greater than an adult. They have very little sub-Q fat. Okay, they have very thin tissue because that skin surface is too thin. They just don't have enough fat. They're going to lose heat. Again, their posture contributes because they're all spread out. Preterm babies have little ability to vasoconstrict, that is superficial vessels, and conserve heat. Okay, so those vessels right under the skin, they can't really constrict them to cause blood flow then to go to the mid part of their body. Gastrointestinal, these babies have poor suck swallow. You'll even see poor suck swallow symptoms on the 37-weekers. You really have to work with them, okay? Because that's what they start practicing closer to the end is suck swallow. They have increased gag reflexes, okay, or poor gag reflexes. Maybe either or. They have so because of the gag reflex being a little bit poorly developed, they are at danger of aspiration. They have problems with absorption. They have a small stomach, so they have a difficult time meeting their caloric needs. They have feeding intolerance due to necrotizing enterocolitis because of the decreased blood flow to those tissues. So these babies do not have good blood flow to their intestines, so they get necrotizing enterocolitis. Okay, what is necrotizing enterocolitis, do you think?
Dying tissue.
Right. The tissue cannot move the stuff through, the food sits there, causes it to build up, and that tissue gets infected, and it causes that tissue to die. It can't move. They're going to have renal problems, difficulty filtrating and excreting. Their kidneys aren't developed yet enough for that. You're going to have to measure the urinary output. You're going to have to monitor it closely, especially if that baby is receiving Gent or Vanc, because they can become toxic. And then they have a risk of excessive fluid overload. So we're going to do peaks and troughs on these babies. So how do we measure urine output? Weigh the diaper, just like we're going to weigh a pad, we're going to weigh a diaper, okay? We're going to see how much is coming out in milliliters by weighing a diaper. Hematologic problems, their total blood volume ranges from 80 mLs per kilogram to 100 mLs per kilogram. So if they weigh 1,000 grams, how many kilograms is that? 1. So they have 100 mLs of blood volume. Think about that. Very, very small amount. Think about 100 mLs on one of those beakers. That much in the bottom. So any blood loss in the preterm baby is significant. Periodic assessments of the hemoglobin should be performed at least for the first week. And again, we're going to do this probably just with a heel stick. Okay, we're not going to do a venous puncture because we don't want to pull too much blood. Complications of the immune system for preemies. These babies have a significant risk factor for sepsis. The risk for infection from mom in utero or during labor is greater. The passive immunity normally occurs in that last trimester. Okay, so we talked about the passive immunity that goes through the placenta, those certain antibodies that can pass to baby from mom. That happens in the last trimester. So then the IgA, which is that, again, the active the passive again, where they're getting it from mom through the breast milk, it helps to protect the newborn from enteric infections that are caused by E. coli and Shigella because it coats the mucosa of the GI tract. Okay. So we want to definitely, once baby can tolerate feedings, as far as even with just a tube, we're gonna try to encourage mom to pump, and we're gonna get that breast milk and give to baby. Okay, that's gonna be the best thing we can do, because it's not just the colostrum for the calorie intake and the immunities, it's also for that normal flora of their abdomen or inside their intestinal lining. So why does the preterm infant lack antibodies?
Because I didn't receive it.
Right,
that last trimester.
right. We didn't make it to that last trimester, close to the end, okay? So if we didn't make it close to the end, we don't have any of the passive antibodies for mom. Now we have no immune system. Maybe we can't tube feed yet because they're intubated, so they're not getting antibodies from mom's breast milk. So they have minimal amount of antibodies at all, if any. Okay, and so therefore they have no immune system. So they're at very, very, very big risk. So those IgAs, those are the antibodies that can only come through the breast milk also. So if we're not getting tube fed, we're not getting them IgAs from there. So skin surface, it's very thin, transparent, tears very easily. They're at an increased risk for infection and developing bacterial sepsis because they have multiple routes of entry, okay? So we have to make sure we have good hand washing, very important. Monitor for any signs of bacterial sepsis, so sudden onset of apnea or bradycardia. And metabolic acidosis, these are signs of sepsis in these babies. Neurologic problems, the closer the newborn can be to term, the better the prognosis, okay? Because that rapid brain growth and development occurs during that 3rd trimester. Okay, remember their brain continues to develop and grow after delivery even, but they really have that growth in the end of pregnancy. Sucking muscle tone and states of arousal are weaker than a full-term infant. And then the last step in the neurological development is the development of the myelin sheath. That's what covers our nerve bodies. Okay. So a big risk for the preterm infant is intraventricular hemorrhage and ICH, intrahemorrhage, intracranial for work. Okay. Which is the most common problem. So do these babies, when we know someone is in preterm labor, do we deliver these babies via C-section or vaginal delivery? C-section if we can, okay? And the reason is because with going through a vaginal delivery, they have a bigger risk of trauma to the head, okay? Going through that vaginal canal. So if we have a woman who's in preterm labor, we can't stop it. They're usually gonna do a C-section. Of course, it's up to mom, but they're gonna give them those risk factors of vaginal versus cesarean. Okay,
I thought the younger the baby, like, the more they could, like, you know, they would be able to shape.
yes,
The smaller they are.
the smaller they are, yes, they're able to come through the canal easier, but because their skin is so thin, those bones are so soft, they have a bigger risk of some cranial damage or brain damage by passing through the vaginal canal.
Oh,
Yeah. So even though they're small and yeah, they would fit really easy, it's still, they have a bigger risk of damage to the head. So that's why we do a C-section, to reduce that risk of bleeding. Because remember, they only have 100 mLs of blood volume. 20 mLs goes into the tissue around their brain or into between their skull, and they form a septal hematoma. Well, then they're already going to be anemic. Their blood loss is going to be great. So we have to reduce it as much as possible. So that's why we do a cesarean. These babies are also at risk for hydrocephalus because of the IVH, the intraventricular hemorrhage. Their tissue surrounding the head and brain is too thin and the vessels are more exposed. Okay, so they can build up more fluid around the brain. Necrotizing enterocolitis. This is a very serious intestinal issue and illness. It's damage to the intestinal tissues caused by perforation, leaks into the abdominal cavity, causing an infection. May cause scarring or strictures within the tissue itself. So if we have stricture in the bowel, what's the problem? What does stricture mean?
Restricted.
Yeah, right. They're not gonna be able to pass stool because it's strictured, it's constricted. Okay, instead of being open, it's come down and closed, and it's scarred that way, so it doesn't stretch like the other tissue does. Okay. And they're gonna have issues with absorption. So symptoms you're gonna see for the necrotizing enterocolitis: abdominal distension. They're feeding, do not digest. They're regurgitating it back up. Bloody stools, bile-colored emesis, apnea, lethargy, bradycardia. We're gonna do an X-ray to diagnose. Treatment is gonna be an NG tube, oxygen, and probably surgery. Okay. So these little guys, one, if we had a preterm deliverer here, that's greater or usually less, we can keep 35, sometimes even 34 weekers, depending on how well they do on oxygen. But if they're younger than that, we usually send them out to another facility because they have a risk of developing things like this at a moment's notice. And we can't do anything about it quick enough, so we have to send them to a bigger facility. Okay.
And they would perform the surgery there, right? Because
Yeah, if
Not
they,
yet.
if they have it, you're gonna have to get that tissue out because it's not viable. So they're gonna do the surgery and remove it.
Where do
which
they,
is really risky, right? Because they leave.
Right, because they're so tiny. Yeah,
where do they usually go? Wichita or Kansas City? or-
just depends. Right now with COVID, who knows? We even do Denver, what's the name of the hospital? Not Shriners, it's something else. But there's, no, it's not St. Jude's, it's the Children's Hospital in Denver. Dr. Lucero likes to send them to. But if they are from Oklahoma, sometimes we'll do Oklahoma City or Amarillo. We try to get them as close to where they're from as possible, but sometimes it just depends on what's available. And the type of availability they have for like cardiology.
And they give babies blood if they look like that young.
Yeah, we can do blood transfusion. We can. So fluid balance. Again, weight change is the most sensitive indicator of fluid balance in the newborn. So we're going to make sure they're well hydrated. Hydration is very, very important. They have to have an adequate intake, and it's based on weight and age. Insensible losses can be minimized by providing humidified oxygen, using heat shields, placing an infant in a double wall incubator. So how do we evaluate hydration statuses? Anybody know?
Measuring the diapers,
Okay, we can weigh diapers,
skin turgor.
skin turgor. We're gonna monitor, how much they're taking in. What else physical wise?
Their weight.
Their weight. We're gonna make sure they're not losing weight.
Color of their urine?
Their skin, maybe the color of their urine, if we actually can collect some urine specimens. Also, fontanelles, okay? If their fontanelles are sunken in, that's a sign of dehydration, okay? Dry mucous membranes and decreased urine output. Hypernatremia, which is hyper high natremia, sodium. Yep. Weight change is the most sensitive indicator of fluid balance in a newborn or infant. So we're gonna weigh those diapers, like you guys said. So normal urine output for a newborn is 1 to 3 mLs per kilogram per hour. Probably something important to know. Kangaroo care What is it and why does it work? That skin to skin. So you get that bonding, right, with mom or dad. You get natural body heat, it's gonna keep them warm. What else is on our skin?
Flora?
The normal flora, yeah, that's gonna help continue to grow that normal flora. It's also gonna improve oxygen. We'll have babies that, maybe you have a baby that's born, has a little bit of grunting, a little bit of retractions, not enough that we're gonna, start oxygen or do CPAP or anything, but we're just gonna continue to monitor baby. Sometimes as soon as you put that baby skin to skin with mom, it stops. That baby settles down, calms down, and looks wonderful from that point on. And it transitions, and you don't have to do any intervention. So sometimes when we have a baby that's kind of just right on the border of maybe we should intervene, but it's not really that bad yet, if you get that baby skin to skin with mom, you're gonna see it resolve almost immediately. Enhances thermoregulation again, and it will stabilize vital signs. Okay, just that interaction with that parent. And sometimes, like I said, doesn't have to be mom, it can be dad.
So are the parents able to stay with them 24/7?
Not always if they're in the NICU. If they're in the NICU, they have certain visiting hours. It depends on the facilities. Like when my friend's baby was in the NICU at Baylor in Dallas, they actually had like hotel suites at the top levels of the hospital that they were able to stay in. And then that way they could go in and out for visiting hours. In Arkansas, when I worked there, Little Rock, they had like little sleep pods in the waiting room that you could reserve for certain times of the day, and housekeeping would come in and change them out, and that way you could kind of stay close. They also had a Ronald McDonald House, but if you have like a baby that was really high risk, you could stay in those little sleep pods so many hours a day to rest, so that way you could be super close to baby. But most of them, until they're stable and can be put in a room, individual room, then the parents aren't allowed to stay 24/7. Yeah. Preterm newborn complications that we're gonna see. So again, we talked a little bit about this already, that baby, that PDA, that patent ductus arteriosus, so that ductus arteriosus sometimes doesn't close on these babies, okay? So that fails to close due to hypoxemia within delivery and post-delivery. So it's a conduit between the left pulmonary artery and the descending aorta. So it's going to shunt blood flow away from the fluid-filled lungs because the lungs are not functional during gestation. So this is in utero, and it sends that blood toward the placenta for gas exchange. So in healthy newborns, this is usually closed by at least 72 hours. Initially, most of the time it's going to be 24, but it can sometimes take up to 72. Closures related to birth weight. A symptomatic PDA increases with a decrease in birth weight. So the lower weight the baby, then the higher risk you have of that duct's not closing. Really preterm infants, like 30 weeks or less, may take several weeks for it to actually close. If you have a symptomatic PDA, it occurs when the left to right shunt via the PDA occurs. So you have blood flow from the aorta to the pulmonary artery, increasing pulmonary blood flow, and this leads to left ventricular overload, pulmonary edema, and CHF. So a preterm newborn is born. It has immature lungs, which then goes and develops into hypoxemia. That PDA then doesn't close because it doesn't have enough oxygen blood flow. Blood flows from the aorta to the pulmonary artery, increasing the pulmonary blood flow. That left ventricular is overloaded, which results in pulmonary edema, which then turns into CHF, which then turns into respiratory distress, okay? So that's why when they do not have closure of that duct, it can cause issues. Okay, causes that overload of blood inside the lungs, which then causes pulmonary edema and CHF. Then if you have too much fluid in the lungs, you're not able to expand and have oxygen supply, so your body starts going into a response and causing respiratory distress. So we're going to identify symptomatic infants of the PDA early. We're going to minimize long-term complications. So these symptoms can include tachypnea, bounding pulses, hypotension and widening pulse pressures, tachycardia, hepatomegaly. Why would it be hepatomegaly if you know what that is? Which is what? Enlarged liver. Why? Because the right ventricular overload causes blood to back up into the veins. Okay? So because of that shift, you're going to have more overload.
You said because of what?
Right. Ventricular overload. So what is our treatment? We're going to have respiratory support for these babies. We're going to have to restrict fluid a little bit and administer diuretics. We're going to have to pull off the excess fluid from the lungs, just like we would someone who does CHF as an older person. Digoxin is used. It helps develop it helps if the CHS is developed while waiting for the PDA to spontaneously close. Then indomethacin. Indomethacin is what is most commonly used to reduce that PDA, to help it close, okay? It's a prostaglandin prostaglandin synthase inhibitor. So it helps the ductal closure by prohibiting prostaglandins that dilate the duct, keeping it open. So the body's responding, I don't have enough oxygen, so I'm going to keep this duct open because that's going to help me get more oxygen, because that's what I did in utero, right? Stayed open, got more oxygen from mom. Well, don't have that supply anymore. So because of prostaglandins are being produced by the body, keeping it open, we've got to inhibit them. We got to stop them from being used. So what it is, that prostaglandin synthase inhibitor. So if you remember from science, okay, this isn't going to be on the test, but just so you can visualize what's going on. You know how we'll have cells and it's waiting for that one thing to activate. Okay, so this is our prostaglandin. It needs its second piece to activate, so therefore it can keep that PDA open. So what the indomethacin does, instead of our normal piece coming in, it comes and blocks it. Okay, so it inhibits that prostaglandin from working, basically. It goes into the place of that other piece to make it work. Does that make sense? That's what an inhibitor is. It kind of takes place of what needs to go in that puzzle piece. The other one is neoprofen. This is one that we use just like the indomethacin. It is also a prostaglandin inhibitor, so it does the same thing. It fills that space so that prostaglandin can't be activated. So a growing preemie will, with increased O2 needs, acidosis, and hypotension, may have a PDA. Okay, not every pretermer has one, but they have a bigger chance of having one than not. And we're going to use indomethacin as our inhibitor to stop those prostaglandins from keeping it open. Again, indomethacin.
What would cause one, like the indomethacin, to be used over neoprofen, or why would they use the other versus the other?
Preference by the physician, usually. Yep. Because they both work the same. It's probably availability, what your pharmacy carries. Because not every pharmacy is going to carry both, especially if they're expensive type of medication.
PDA also causes
Possibly, but you're going to see it more just in a baby that's hypoxic. Yeah, but if they're hypoxic because mom was a substance abuser and they have respiratory distress because they're going through withdrawal, then yeah, it's related. Okay, apnea. This is when cessation of breathing occurs for 20 seconds or longer. Okay. So on a newborn, it's a little, you can't say if they go 10 seconds without breathing that they're apneic, Because are they regular breathers? No, they're irregular breathers. They're gonna kind of hold their breath every once in a while. But if they have periods greater than 20 seconds or longer, then that is considered a period of apnea in a newborn. Okay? Cyanosis, pallor, and bradycardia during any length of this time is going to be also an indicator of apnea. This is most common in your pretermers that are less than 36 weeks. It's thought to be a result of the neuro immaturity in these babies, which contributes to more irregular breathing than just a normal newborn. You can also have obstructive apnea. So this is cessation of airflow associated with blockage of the upper airway. So improper body alignment, secretion, and they have a smaller airway, okay? So most preemie babies are gonna have what's called a car seat test before they go home. And what they do is they put the baby in the car seat with pulse ox on baby, and they're gonna leave them in there for 30 minutes or so, and they're gonna see, does that baby start to desat? Because what happens when a baby's in a car seat? Their head goes forward, right? And so because of that, what happens? You're cutting off your trachea. So these babies, if they're not aligned properly within a car seat, then we've got to make sure that they're not going to desat. So they're going to do these car seat tests before they send them home. If they cannot maintain their saturation while sitting in a car seat, they cannot go home yet. Okay? Because we know it's inevitable at some point a baby's going to go in a car seat or a bouncy seat or a swing. Okay? And then they're not going to be able to maintain their O2 saturation. Intraventricular hemorrhage. This is the most common type of intracranial hemorrhage in a small preterm infant that's 1,500 grams or less than 34 weeks. They're going to do a cranial ultrasound to assess. The most common site is in the lateral ventricles of the brain, where most blood supply is, and capillary walls are thin and fragile. Before 32 weeks, they're much more susceptible to this due to blood pressure fluctuations and hypoxia from respiratory distress syndrome or birth trauma. So what are our treatments? One, we're going to try to prevent preterm birth. When that mom comes in preterm labor, we're going to give terbutaline, okay? We're going to give betamethasone to mom to try to allow baby's lungs to mature. We're going to hold off on labor as long as possible, okay? We're going to possibly do a C-section because that is going to reduce trauma to the head. Postnatally, we're going to then assess baby, do what we can. We're going to do careful resuscitation because, again, they're teeny tiny. They're very susceptible to bleeding easily. So, yes, we need to resusc, but we have to also be cautious on what we're doing. We're going to try to correct any kind of coagulation abnormalities, reduce seizure chances with phenobarb. And the outcome of this baby depends on how big that bleed is. Anemia, this is a risk due to rapid growth rate required. So remember, these newborns, their RBCs don't live as long. We're having to do excessive blood sampling. We got to check and make sure everything's healthy on baby. And they have decreased iron stores and deficiency of vitamin E. So the hemoglobin reaches its lowest level at 8 to 12 weeks and remains there for 3 to 6 months. So on these babies, we're going to intervene with some iron supplements and erythropoietin. That's one of my favorite words to say, erythropoietin.
How long does it stay at that level? You said 3 months?
3 to 6 months. Once they're discharged from the hospital, the newborn's going to follow up, and this is very important. We're going to do lots of education to these moms and dads, okay? The first year of life, the preterm, low birth weight infant has higher mortality rate than a term infant. Their risk for SIDS is 5 times more likely. So normal or newborn congenital anomalies that we can see, hydrocephalus. It's an obstruction and flow of the cerebrospinal fluid, resulting in ventricular enlargement. You're going to see enlarged fontanelles, okay? They're going to be bulging, split or widening sutures. Their head circumference or measurement is going to be greater than the 90th percentile. Things that you're going to see on assessment, you're going to see also sunsetting eyes. And you know what that is. So sunsetting eyes is where you actually look and it looks like the baby can only look down. And it's because of the added pressure from behind their head from that fluid, okay? So they're not able, it looks like they're only able to look down. Choanal atresia, this is a bony occlusion of the posterior nares, okay? You're going to notice cyanosis, noisy respirations, dyspnea during feedings. You're going to see thick mucus obstructions on these babies. And it's because they have a blockage, okay, in those passageways. Cleft lip and palate, this can be unilateral or bilateral, so it can be one side or both. May involve exterior nares, the nasal cartilage, or even the septum. Flattening or depression of the midfacial contour, so you're going to kind of see more flattening here, okay? You're going to notice an obvious deformity usually, okay, but not always. Remember my example of my baby that didn't have a uvula, okay? That was actually a cleft soft palate, but that was the only issue she had, was just no uvula, okay? Most of the time you're going to see with the lip for sure, because it's the exterior. Now the palate itself, you may not see until you do that physical assessment where you're doing that suck assessment and you're also feeling that palate, okay? So it's a fissure connecting the oral and nasal cavities when it's a palate involved. You're going to have involvement of the uvula and soft palate. They're going to have difficulty sucking, expulsion of formula through the nose. These babies are going to be on aspiration precautions. Why? Yeah, because of sucking, swallowing, and then think about your nasal cavity is connected to the back of your throat through your eustachian tubes, right? And so, and then your sinus cavities, and so it's going to come through the nose, not just through the esophagus, to get to be able to go into the trachea. Okay.
So do you try to keep those babies
Yes.
sitting?
When you feed these babies, you're going to have them in a very upright position to reduce the risk of it getting into the nasal cavity. You're going to feed with a special nipple or bottle, and these nipples actually are pretty neat. So you're going to have the bottle itself, and it's a long nipple. And so that way the opening is here, and this is actually a very wide nipple that goes in the mouth, and that when they suck, then it's going to be more to the back of the throat than just the typical nipple. And you want to get as much of it in their mouth without choking them, because you want it to go to the back of their throat. Okay. You're going to burp these babies frequently because they're going to tend to pull in more air. Okay. On the cleft palate, there's a fissure connecting that oral and nasal cavity. And so you can have cleft lip and cleft palate, just cleft palate, cleft lip. Okay. So it can be the three, either the combo of both, just the lip or just the palate. Okay. And on the palate could be soft or hard palate involved. So a tracheoesophageal fistula, TE, okay? So with that term, tracheoesophageal fistula, without reading what it is, what do you think it is?
trachea and esophagus are like attached.
Correct. There's a connection between your esophagus and your trachea. Okay. So it's an abnormal connection between these two. You have usually an antenatal history of mom having hydramnios or polyhydramnios, okay, the excess fluid. Following delivery, these newborns display excessive oral secretions, constant drooling, choking and cyanosis episodes. They are a big aspiration risk. They develop aspiration pneumonia due to gastric contents refluxing into the trachea. When you try to place an NG tube, you're unable to pass it because of the blind pouch of the esophagus. So it's going to coil back to you. Diaphragmatic hernia. Anybody know what that is? So your diaphragm is herniated. There's an opening. So these babies are actually born where part of their intestines has developed inside their thoracic cavity. Okay, because that diaphragm is not intact. So the newborn has difficulty initiating respiration, because think when they're taking that big first gasp, they're opening up those lungs. But now I have part of my intestine and stomach in here. Maybe my lung wasn't able to fully develop on one side or the other or both because I had something obstructing the development of it. They're going to demonstrate gasping or nasal flaring. They're going to have a barrel chest, okay, just like you would with someone who has a COPD. It's going to be enlarged and barrel-like. Their breath sounds are going to be absent unilaterally, and usually it's more so on the left. Their heart sounds are going to be displaced, usually to the right. And where do you think we would be able to hear bowel sounds? In the chest, okay? You would be able to actually hear audible bowel sounds in the chest because there's intestines in the chest. Do you think these babies do very well? No. And a lot of times, if say maybe mom doesn't have a lot of prenatal care, we didn't get an anatomy scan early on, we may not even know this baby has it, right? And so you have this baby born having difficulty breathing. We're going to have to get them out of our small rural area quick to try to get it fixed. But sometimes these babies, if their heart was displaced and development was stalled or lung development wasn't able to continue to occur, they don't do well. Myelomeningocele, okay? This is a sac-like cyst with meninges, spinal cord, and nerve roots in the thoracic lumbar area. These babies usually have no sensation or response to those lower extremities below the defect. You're going to have constant dribbling of urine or stool. You may have an anal wink. You may know what that is. Okay, so you're going to see a constant just kind of movement of the anus because it has no control, basically. Okay. Interventions, you're going to cover to prevent drying and rupture of that sac. We want to do a wet, sterile saline soaked dressing. We're going to administer antibiotics such as ampicillin or gentamicin. We're going to position to prevent damage to the sac. Handle that baby with care as much as possible to decrease rupture of that sac. You're going to diaper the baby with a mud flap. Okay, so basically what you're going to do is you're going to fold the diaper over, inside or out, either way you choose, to keep it from covering that back. Okay. And you're going to monitor for hydrocephalus. This is a baby with a myelomeningocele. Okay. So it's a sac on the spinal cord. It can be anywhere, but it contains part of the spinal cord, part of the meninges, which are what? Our nerves, right? That's what our nerves are attached to. And part of the nerves themselves, the nerve roots.
What happens if it ruptures?
I mean, you're looking at big risk of infection, damage, further damage, nerve damage. So than what you already have. Your biggest thing is then you're gonna lose the cerebral spinal fluid. And then you're gonna then not only have issues with your spinal column, but also your brain because it's connected. Okay. If we are aware that they're there, yes, these would be born via C-section because you want to again reduce that risk of rupture.
You can't do anything about it.
In utero,
No, that's what babies.
after it's born, yes, they're gonna do surgery to try to correct it, but they're not gonna correct the paralysis, basically. Can't correct that. What do you say?
It's the same thing.
Okay, yeah, you can do corrective surgery because we need to close up that area. But of course it needs a specialist, and then also you're not gonna repair the nerve. Now, over time, does that not mean that the body might naturally repair and you have some movement or sensation back? Potentially, but you know, there's no way to permanently fix it to where it's gonna change all the way, unless there's a miracle, and they have. Okay, so omphalocele. So this is when we have the intestines, when they're forming inside the baby. Remember how we talked about on our progression through growth, development. Those develop outside of the body, right? Our heart does, our intestines, they all develop outside of our body. And with the intestines, it's inside that actual umbilical kind of sac. And once they're formed, the body kind of closes in around them and makes the umbilical opening. So when you have an omphalocele, what has happened is the abdominal wall has failed to close during development around those intestines. So they literally are still inside the umbilical sac. So with the omphalocele, we have omphalocele, and then you have gastroschisis. They both have intestines outside of the normal area. How do we know the difference? Okay, omphalocele, we have a sealed sac. Okay, omphalocele, you have a sealed sac. You have a sac around that intestine. Okay, again, I'm a word association person. I'm going to teach you what I like. Okay, so with these, our interventions are: one, we need to keep that baby breathing. We're going to cover that sac with a sterile bag and warm saline dressing. So we're going to get gauze with warm saline. We're going to cover it, and then we're going to put a sac around it. On gastroschisis, do not use fluid. You do not use sterile gauze and saline. Omphalocele, you can, okay? Because you want to keep moisture on that sac because we don't want the cord to dry out. Okay, that's what we're trying to prevent is the hardening of that cord tissue itself, because then we need it to be put back in. So, but with the gastroschisis, we don't, because we do not want to then cause issues with the actual intestines. We're going to cover the gastroschisis with a sac, but not the dressing. Okay. So with the omphalocele, we're going to do antibiotics. We're going to do an NG tube. We're going to try to prevent rupture of that sac. You want to do a sideline position for baby. So that way it has optimal bowel perfusion, just like a mom. If we have her flat on her back, she doesn't have good perfusion to baby. Same thing with babies. We don't have good perfusion to the organs if they're laying flat on their back. Okay. We're going to maintain fluid and electrolyte balances with IV fluids. And we got to maintain thermoregulation, because these babies have a greater risk of losing heat because now their bowels are out in the open air. They've got more body surface area that can then lose heat. So gastroschisis, this is where the intestines are actually outside of the body. Okay?
How fast does the surgery have to be? to get it?
Usually pretty quick, but they also have to look at making sure, you know, inflammation goes down, that the intestines can be replaced. Sometimes they have to have tissue to cover once they get it back into place. So usually it's pretty quick, but it's not going to be like always the same day. Okay. So tables, or with, if you're one, turn around to your partners around you. I want you to discuss, how would you assess this baby? What do we need to look at? Discuss some risks to this newborn. And what nursing interventions would you implement based on these risks? With your partner or the person behind you. Real quick, and then we're gonna discuss it as a group.
Is it like that just because it's a woman?
Yep.
Do they still have like higher chances of surviving?
I mean, their survival rate is pretty high because, as long as if it's known and they're born where they can take care of it pretty quick, even if they're born like here, we've had a couple here, just, maybe shouldn't have a lot of prenatal care. And then we get them to another facility quickly, but their rate's a lot higher than if it was something like the Omnipocil or something else. Or, I mean, the myeloma Ninjacil.
Whenever they're born like that, are the intestines themselves, or can they be born?
It can. Yeah, they're at a higher risk of having tissue breakdown and having, but cover, contain, and then get them somewhere to live, then they can start the process of putting it back in. And it can be a long process. It's not gonna be where they can just stick it back in and sew it back up. Like sometimes they, like I said, they have to stretch the tissue, you have to grow the tissue. So it can be a process.
And the myeloma. Would you say that?
Yeah, usually they have no movement from that down, from their, wherever their deformity is down. Okay, so real quick, what are some things we're gonna assess on this baby?
Vitals,
Okay, vitals.
swelling,
Okay, we're gonna look for swelling.
any drainage or bleeding.
Right, we're gonna look, yeah, we need to see, do we have any perforations? Do we have any bleeding? Do we have any open areas?
Reduce the risk for infection with antibiotics if we need to.
Yep, we're gonna try to reduce risk of infection. So initially it's gonna be with covering, and then probably antibiotics prophylactic. Right.
perfusion, like? for
Yeah,
blood?
we need to check perfusion. You know, do we have good perfusion? Do we see good color? Okay. Do we see white or dusky? White or dusky, does that mean we have good blood flow? No. Okay, white or dusky means we have poor blood flow. We gotta see then how can we reposition maybe to get better blood flow. So what are some risks to this baby? Infection. Okay, infection's big. What else? Heat loss, right? Because we have more exposure. Okay, they're gonna be a big risk for thermoregulation. They need them to be warm. Okay. Anything else?
At what point do you start scheduling the surgery or calling?
So if this baby was born here, we would get it shipped as soon as possible. And then from there, you know, the surgery's not always going to be done immediately, because sometimes you do have to look at getting swelling down, maintaining, if there is an infection, getting that under control first. And then plus two, there's not always enough tissue to close. So like that baby you saw, that was probably one they were working on getting that tissue to grow. So they were able to get the intestines majority back in, but they were growing the tissue, you know, where they actually put like a fluid-filled balloon under the tissue to expand it to allow it to grow. So then they can close up.
When they fly them out like that, is there anything special they have to have, like to put them on a plane?
Oh, yeah. I mean, when they come in, because usually a team comes from the facility where we're flying them to. It's not just a typical like life team flight. It's an actual team from that facility that has usually a neonatologist, a NICU nurse, a respiratory therapist, and sometimes a paramedic. And then they have like a whole cart, just like they would put a full-size body on, but it has an incubator and it has your ventilator, it has oxygen, it has your IV pumps, and it's all created to work together. And so, yeah, as soon as that staff comes in, if I was the nurse in the nursery, I would give them a report and basically hand off, and then that baby's theirs. And then they do what they need to do to baby. If they need to start another IV, if, you know, they feel like, you know, baby's on CPAP, but it needs to be tubes, they're gonna then do an ET tube. You know, whatever they feel like needs to be done, because now my care that we've had, we've handed off to them. And they're gonna do whatever they need to do to finish stabilizing that baby to then transport it.
Did they even send a doctor?
But yeah, some places, depending on what the case is, what's going on with baby, sometimes you'll actually have a neonatologist that comes with the team from the facility. Yeah. So you have your own little hospital team right there that picks that baby up and then cares for that baby through the whole flight until they get to the facility. So kind of like a mobile hospital.
Survival rate on this.
It's pretty high. On gastroschisis and omphalocele, pretty high. One of my best friends from high school, her oldest daughter had gastroschisis, and now she's 14 years old and has no issues.
How long does it normally take, like, if they had to grow the skin?
It just
and
depends.
put it-
I mean, it can vary. Depends on some babies, maybe once they go in and they got reduction in inflammation, they can get it back in and it can close right back up. Other babies, depends on how big the defect is. Yes, most of the time, like my friend, she knew she had it, so she delivered at Baylor, Dallas, because they had a specialized team there, for her delivery, a doctor that specialized in gastroschisis. So she did deliver, because she knew she had it. Most of the time, the only time, like we have had a few here, but it's usually those people that have little to no prenatal care, you know, and haven't had any scans. You know, because if you have a 38-week baby you're trying to scan, you may not be able to see every piece and part because they're so big and compact in there and you may not see it, you may not catch it.
What is there a reason why this happens, or it just happens?
It's sometimes this is one of those things that's just kind of random. Yeah, there's not really a significant, we know if they're exposed to this or mom has this congenital anomaly or whatever. It just happens. It's a random disorder. Okay, so we're gonna talk now. So gastroschisis is where you have a full thickness defect in the wall. Okay, so it's not in that little sac, it's not inside the sac of the umbilical cord, it's actually outside of the body in the open air. Okay. So we're gonna take this baby, once it's born, we're gonna place the newborn in a sterile bag up to the axilla. We're gonna use saran wrap, literally saran wrap. Literally a Ziploc bag. If you look on our cart, that's what we have. We have gallon-sized Ziploc bags or saran wrap, okay? No, because we're outside of the sterile environment, you know. But we need to keep the heat in, we need to keep the moisture in, okay? And we're gonna try to avoid actually putting pressure on the bowels. We do not cover with a sterile gauze, okay? And why would we not cover this one, do you think?
Cause they can't see, and then like it'll dry and stick onto the.
Okay,
bottom.
dry and stick, you can't
Well,
see,
it's already not sterile.
not sterile, but that, yeah, it doesn't matter if it's sterile, but that salaine's gonna cool, okay? And it's gonna draw heat out faster, okay? Now, on the other one, yes, we still have the same risk and potential, so we're gonna be constantly changing out with warm sterile gauze, but with it, we're trying to prevent that tissue from drying out, okay? We're gonna need to maintain hydration, so this baby's gonna get an IV, an NG tube. We're probably gonna do antibiotics prophylactically just to prevent the risk of bacteria growing and causing an infection. So I thought this little picture was a good visual again, okay? Your omphalocele is in the umbilical cord sac. Your gastroschisis is outside of the body, not in the sac. And again, it's omphalocele in a sealed sac. Gastroschisis is just out. Prune belly syndrome. So on prune belly syndrome, these babies, it's also known as Eagle-Beret syndrome. There's an absence or severe weakness in the abdominal muscles. Okay. Usually there's an absence of descended testes in the male, so they haven't come down. You're going to have abnormal expanded bladder and problems within the can be born stillborn or they die within a few minutes. So tell me what, if we have a baby that's born with a prune belly, what is your biggest risk after delivery? What are you thinking about? Breathing, right? Because they're belly breathers, right? That's how newborns breathe. And if they have weak or absent muscles, they are not going to be able to breathe as well and as easily.
So do they all die?
Not necessarily, but they have a very high mortality rate. You're going to see that these babies usually have oligohydramnios because, why? What is one system that we said it does affect?
The respiratory?
Bladder. Or they may have upper urinary issues. Okay, so if the bladder or the kidneys are not functioning properly, remember that's how we continue to make some of our amnio fluid, is baby swallowing and peeing, swallowing and peeing. And if they can't pee appropriately, we're not going to have enough fluid. So you're also going to see loose hanging wrinkled skin and a shapeless abdomen. And we have to definitely maintain respiratory status on these babies because again, they can't breathe well because they don't have that muscle support from the abdomen and they're belly breathers. So these babies are a higher risk of having to be intubated. Imperforate anus. So this again is the absence of the anal opening, and we talked about this a little bit yesterday. They may have a fistula, so they may have a slight opening, but it's not a complete opening. Boys, between the rectum and the urinary tract system is where you're going to find a fistula possibly, or scrotum, penis, or perineum. Girls, you're going to see one between the rectum and the vagina or the perineum. So on assessment, you may see no rectal opening at all. Sometimes you can see what looks like to be an opening, but then you just never have passage of stool after 24 hours. The big thing is you do have to be careful because if there's a fistula, between the actual upper anus, not the actual opening sphincter, and the vagina, and it comes out, you can, oh, the baby poops. Because maybe it looks like it has an opening, but maybe it's not completely patent. So it poops from the fistula. They are going to have gradual abdominal distension over time because they're not able to pass the stool. So interventions, we're going to inspect for anal patency on physical assessment. And again, we do not do the rectal temp anymore. We don't want to perforate. We're going to inspect for a fistula, and you may not always see it. Okay. Maintain fluid balance, and these kiddos are going to have an NG tube placed until they can have their imperforate anus fixed.
I have a question.
Yes, ma'am.
So I seen one of those and
Uh-huh.
like the abdomen was already distended and then like it was like swelling on his bottom.
Uh-huh.
Does that put him more at risk for like their bowels to rupture?
Yes. Yes. If it cannot pass, then yes. So the tissue inside the small intestine, large intestine can only hold so much. So yes, they're going to have a risk for perforation or leakage. So yeah. So screening tests that we're going to do on babies. And so someone asked yesterday, so I clarified. With the PKU, most states, it's a law. You have to draw a PKU on a baby. So a parent cannot technically deny that test. It's most states it's required. It's a mandated law that they have the PKU test done. And again, if parents are educated on why we're doing it, most people are going to say, well, of course, I want to make sure my baby's healthy and has no complications that can be easily fixed by changing its diet, you know. So, but there are some states that don't mandate and it's not required by law, but most states require it by law, has to be done, okay? So PKU, that's where they have the lack ability to convert phenylalanine, so it doesn't process those proteins appropriately, okay? So you have a higher protein accumulation inside the bloodstream. Another test we look for is maple syrup urine disease, and it's fatal if it's untreated, okay? And the pee actually smells like maple syrup. That's where it got its name, okay? Homocystinuria, this is a skeletal abnormality. It's a deficiency of the enzyme cystathionine beta synthase. Cystathionine beta synthase. You usually don't have any symptoms in the newborn period. You're going to treat with high doses of B6. Galactosemia is a carbohydrate metabolism problem. Your body cannot use sugars like galactose or lactose. So it's unusually high levels of galactose circulates in your blood, causing cataracts, brain damage, liver damage. Symptoms you're going to see with this is going to be vomiting soon after ingesting milk. Why? What's in milk? Lactose. Okay, lactose is a type of sugar. Diarrhea, poor weight gain, jaundice. So they're going to have to be on a galactose-free diet. So these babies are going to have to be soy formulas. Congenital hypothyroidism. These babies, you'll note, will have a large tongue, possible umbilical hernia, the mottling where they have the lace look on their skin, okay? Less than 30-week infants usually have a lower T4 and thyroid stimulating hormone, so they're at risk for hypothyroidism, and they may have to take some thyroid medication. So resuscitation. So rapid assessment for resuscitation. So if we have a delivery, at any time we have a delivery in OB, we anticipate that we are going to have to resuscitate that baby, okay? Because we don't know if that baby that has a happy, healthy strip, looks good, good variability, which moderate variability means what? Okay, it's 6 to 25 feet, but what does it mean for babies? It's good. We've got good oxygenation. We've got a good baby. Okay? So if we have moderate variability, and the variability is different than a variable B cell. Okay, variability is just that change in the wave of baby's heart. Okay. So if we have a baby that has good variability, no D cells, that baby could still come out and not want to breathe. Okay, because it may have some other anomaly we don't know about. So we always get ready to resuscitate a baby. So we have our warmer in there, we have our oxygen ready. We've made sure that our CPAP works and we're on the right pressures. Okay, so when you go in to do your rotation through OB this semester, you're going to look at those things. You know, if you get to be in on a delivery, watch that nurse. She's going to turn all that stuff on. She's going to check it, and then she's going to turn her oxygen back off because we don't all need to be hyperoxygenated in the room. Okay, but it's going to be ready. So all we have to do is flip the switch, and we know it's set to where it needs to be set. Okay. So if I'm going to come in and say, you know, someone's called me into the room. They think this is going to be a baby we're going to have to resuscitate. So there's some things I need to know. Okay. Prior to delivery, I need to know the 3 T's. Is this a term baby? Is it twins? And are there turds? I know what a turd is. Poop! Meconium, right?
Okay.
3 T's.
I thought it was maybe like a synchronym.
Nope. Nope, not an acronym.
Or acronym, yeah.
It means turds, it means poop. Okay, so do I have a term baby? Is there more than one baby? And is there any meconium? Okay, so if I remember 3 T's, those are things I need to know when I'm walking in that room to help resuscitate a baby. Okay. What other risk factors do I need to know?
If the mother's diabetic.
If mom's diabetic, right? Hypertensive.
Any complications with the pregnancy?
Complications with pregnancy. What you say, Brady?
Maybe mom has an STI or stress.
Yeah, exactly. We need to know, does she have GBS? Does she have STI? Does she have HIV? Does she have Hep B? Okay. Because me as a nurse, I'm going to be catching this baby that has what on it? Blood from mom. So I have a risk of being exposed. Okay. Baby has the risk of being exposed. So we need to know these things. Anything else?
She was a drug user?
Was there any drug use? Did she get any drugs, medications in labor? When was the last time she had pain medications via IV? Because what if it was just 30 minutes ago and it was Demerol? I may need some Narcan for my baby. Because if it doesn't want to breathe, if I give it Narcan, it's going to help pull that from its system and it's going to want to breathe again. Okay. So after delivery, then we're going to look. Is the baby term? And how am I going to tell if the baby's term? The Ballard score. Right. And we can, even if I don't have my paper, there's things I'm going to know. I can look at the bottom of its feet. How many wrinkles are there? What do the breast buds look like? What does the skin look like? Is it peeling? Is it split? Is there lanugo? Do I have vernix? I know those things and I can assess kind of as my knowledge goes along as a nurse and OB, what goes with what gestation. Okay. Is baby breathing and crying? Okay. So I'm gonna first look, okay, what's baby look like? Is it small? We're supposed to be 38 weeks and I got a 4-pound baby. So is it really term? Am I breathing and crying? Okay. Does the baby have good muscle tone? That's the other thing we need to see. Because remember our APGARs, we're looking at appearance, grimace, color, heart rate, respiration. Okay. But always remember your most important thing is we got to make sure baby's breathing. Your ABCs, airway, breathing, circulation, and then temperature. So we're going to clear our airways. And we're going to stimulate that baby. We need to suction the nose and mouth. Stimulate by rubbing its back with a blanket. Dry that baby off. Get rid of your wet towel or wet blanket. Get a new one. Okay. If you don't see any respiratory effort, then we're going to have to probably start some positive pressure ventilation. Okay. So on an adult, what do we use? We do CPR, but we use a what? A bag, an ambu bag, right? Years ago, when I first became an OB nurse, we still used an ambu bag on babies. Okay. It was a neonatal bag and it had what was called a pop-off valve. Okay. So that way, if you got above 30 millimeters of pressure of mercury, that valve would pop, and so it would push more than 30, ideally into the lungs and cause a rupture in the lung, okay, pneumothorax. But now we have what's called a neopuff, okay? So our most warmers have it built into the system. If not, you have a little one you can pull around with you. And it's the same thing as basically an ambu bag, okay? So you set your pressures, has a little round mass that you put over baby's face, and then you're actually gonna just use your thumb to give the oxygen, okay? You can do CPAP also, where you put the mask over baby's mouth and you're not gonna be giving the breath, you're just gonna hold it there so it gives pressure. So with every breath baby takes in, there's a little pressure behind that breath to help open those alveoli and for it to breathe, okay? But if I have no respiration and I need to start bagging this baby, then I'm gonna give positive pressure ventilations. And we're gonna do 40 to 60 breaths per minute, okay? Because that's what a baby's range is, okay? Now, when you're going through this and you're super anxious, you're gonna probably hyperventilate at first. So you gotta think, I gotta get in a rhythm, okay? And usually I do 1, 2, 3 bag, 1, 2, 3 bag, 1, 2, 3 bag. And then I'm like, okay, you gotta slow down. 1, 2, 3 bag, 1, 2, 3 bag, 1, 2, 3 bag. And the reason I say bag is because years ago, I learned by bagging, okay? Even though I'm not bagging per se, I am, okay? So then we wanna monitor our pulse and heart rate. So if I'm resuscitating a baby, is it just gonna be one nurse there? No, you're gonna hopefully have 2, possibly 3 there with you. So while one person's bagging, another person's gonna be slapping on the pulse ox, okay? So that way we can get an oxygen level. We can also get a heart rate, or someone's gonna be auscultating with a stethoscope and listening. Does anybody know another way you can tell a baby's heart rate without listening? If you put your fingers at the base of the umbilical cord and kind of hold it, not tight, you can still feel the pulsation of the heart rate through the base of the umbilical cord, okay? So that's another way you can feel if you don't have a stethoscope readily there. Sometimes you can lay your hand on their chest and you can feel the heart rate, but you can also do it with the base of the umbilical cord, okay?
I'm checking the.
No, just in a newborn, because that's the blood flow there. Once it stops, it stops. So you're gonna check the baby's heart rate. If that heart rate is below 60 beats per minute, we're gonna start chest compressions. Did I say 0? No, I said 60, right? And that's because a baby's heart rate is what normally? 110 to 160. So if they're only at 60 beats, is their perfusion gonna be good? No, it's basically like 0, okay? So that's why we start chest compressions if it's below 60, okay? The pulse ox should increase to 85 to 95% at 10 minutes. So I don't even have my percentages memorized by my range, but every one of our warmers has it on the warmer. So I can quickly look up, see where I am on my timer, because we have an at-bar timer. So as soon as that baby's born, you can hit that timer, and it's gonna tell you at what minute approximately you're at. And you can look at your little thing, okay, I should be at 70% now. Should be at 75% now, okay? So then I can assess, because remember, I'm not gonna reach 90% so close to 10 minutes potentially. You might get there a little faster since you are providing oxygen, but if I don't, and it's still, we get to it at 10 minutes, I'm good, okay? Then, if this baby is still down, we've probably moved from inside my labor room to the nursery, okay? Because we can only do so much within the inside the labor room on the warmer. We're gonna at some point have to move to the nursery. If the baby needs an umbilical vein catheter, which is what is called a UVC, then we're gonna have to go to the nursery because this is a sterile procedure. So on these neonates, a lot of times, if they're down or if they've had hemorrhaging, are you gonna be able to get a line in on those little teeny tiny guys? Usually not easily. So you're gonna have your physician is gonna come in and they're gonna do what's called an umbilical vein catheter. So it's where they actually take a catheter and run it through the umbilical vein into the body system. Okay, and that's where you're gonna administer your medications, your fluid. Only done by a physician. Unless you have like a PA or something like that, but usually never a nurse. Never seen it done by a nurse.
What was a PPV? It was positive.
Positive pressure ventilation. Okay. If, say, we don't have the UVC in place, and I need to give that epinephrine, where else can I give it? Besides.
Crash cart.
It's in the crash cart, but where am I gonna give it? How am I gonna give it to that baby?
I am.
Not muscular. Nope. Nope. We're gonna drop an ET tube into their lungs, and we're gonna give them epinephrine in their lungs. Okay. A tracheal tube. We're gonna drop a tube, and we're gonna give them epinephrine that way. We can also do the Infocert for surfactant that way if they need it. But you can administer through an ET tube. Now the dosage is going to be a little bit different than what it would be if you were doing through the umbilical catheter. Okay. And I don't expect you to know the dosages. Okay. Because even as a seasoned nurse, sometimes I don't remember. And again, we have our NRP guidelines that are right there beside our cards. And that's the reason we have them. Okay. So let's talk about a cold stress newborn. So a newborn's temp usually is going to be 97.7. And I think your book says 97.5. Okay, but 97.5 to 97.7 is not that big of a difference, but 97.7 to 99.7. Cold stress leads to compensation. Okay, we're going to have increased respiration. We're going to start metabolizing that brown fat. If they lose that brown fat, they can't get it back, right? It's gone. Preterm and SGA newborns are the biggest risk for cold stress, and also post-mature babies. The preterm and the SGA baby, they already have that decreased adipose tissue, along with some of those post-term babies. They've already used up that nutrition, that fat inside the uterus because the placenta stopped working sufficiently. If these babies are not able to respond to cold the way their body's supposed to be through those mechanisms of brown fat and metabolism, they're going to have hypoxemia, intracranial hemorrhage possibly, hypoglycemia. If these conditions are present, we need to make sure that their temp is monitored closely, okay? I always say to new nurses, hypoglycemia and hypothermia almost go hand in hand, okay? If you have hypothermia, you're going to have hypoglycemia, okay? Now, just because you have hypoglycemia doesn't always mean you'll have hypothermia, but they're still at bigger risk, okay? So if you have one diagnosis, you need to make sure you watch closely for the other, either way, because they both are going to almost go together all the time. Especially if you have a hypothermic baby, you're going to expect hypoglycemia almost every time. So a newborn with hypoglycemia, this is when that blood sugar gets below 40. We want to encourage early feedings. If that value doesn't improve or it stays between that 20 to 25 range, we're going to do the IV. These are most common with your diabetic moms, your SGA babies, twins, preeclampsia, boys. You guys are always problems. I'm serious. And this is just from many years of experience. But white baby boys, they're your worst one. Seriously, they cause the most problems. They really do. Statistically, if you look at it, they do. Symptoms. These babies are gonna have lethargy, poor feeding, poor suck. They're not gonna be able to maintain their temp. They're gonna have pallor, cyanosis, apnea, tachypnea, hypotonia. They're gonna be flaccid. Tremors. Okay, remember again, babies don't shiver because they're cold. Their body's not made to do that yet. If they are jittery or shivering, we need to assess the blood sugar. Jerkiness, jitteriness, eye rolling, high pitched scream, okay? Or this is when that exaggerated Moro. Remember how he talked about we do the startle reflex, but if they're really startly, then we need to check, make sure they're not hypoglycemic. Initiate those early feedings. We are not going to do glucose water. We're going to identify newborns at risk, and we're going to monitor every hour for 4 hours, every 4 hours for 48 hours. Okay. Procedure for obtaining blood sugar, we do a heel stick, and this can be found on in your book. Always remember, if you're doing a heel stick on a baby's foot,
On the outer heel.
I live to draw. Yes, you're going to be doing it here. Okay. We don't do the base or the bottom of the foot. You do it on those outer areas of the heel. Okay. Always. Not so much on the side, but just kind of at that curve on the outer edges. If you're not able to get a temp on a baby, it seems like it just keeps, the machine's not wanting to do a temp, check their blood sugar. Again, they go hand in hand. So a newborn with jaundice, Icterus neonatorum. This is yellow color of the skin or sclera. It develops when you have that yellow pigmented bilirubin in the lipid fat containing tissues. You're going to screen prior to leaving the hospital. And here we do transcutaneous instead of a heel stick and gathering blood doing a total that way. We just use a little transcutaneous light. Causes RH incompatibility or ABO incompatibility. And we're going to talk about this in a couple weeks, okay? More. Medications exposed in utero. Hemolysis. What's that? Nope. Hemo is blood. What's lysis? Split, breaking it up. Right. So remember those RBCs through delivery, they get broken up. Okay. So we've got hemolysis going on. They have increased red blood cells sometimes, but they have hypoxemia. So we're going to have higher amount and they're going to have a risk for jaundice. Preterm newborn, lack of albumin for belly to bind to, hypo or hyperglycemia. And this can result in neurotoxicity, encephalopathy if untreated. So jaundice is a big deal. It's not just a thing that you're like, oh, they're a little jaundice. It can be a big deal. You can actually cause brain damage in babies if you do not take care of it. So we need to identify those babies at risk. So newborns are the first, okay, we need to make sure baby's term because preterms are at a bigger risk, our postterms are at bigger risk, okay? What was mom's blood type? Identify symptoms of jaundice and rise in the Billy level. So we're going to check that initial Billy level after 24 hours, unless we see that they're already starting to have a yellow look, and then we can assess it before then, okay? When a baby is jaundice, you want to encourage frequent breastfeeding or formula feeding to help stimulate the bowels. Because how are we going to get rid of this Billy? We're going to poop it out. Okay, we're going to poop and pee it out. Phototherapy may be needed. Okay, we're going to discuss that in a minute. Or you may need to be treated with exchange transfusion in order to rid the body of serum elevated bilirubin levels. So they actually may have to do a transfusion if it's significantly high. If it's high, that high, if they're here, they're going somewhere else. Okay, we're not going to do that here. That's because they're going to go to a higher level hospital. So phototherapy, we're gonna put this little baby in a suntan booth. That's what it looks like, okay? So we're gonna expose the newborn to a bank of light, or we also have a blanket that has the lights in it that you can wrap around the abdomen, okay? So depending on the level, if it's a really high level of bilirubin, then you're probably gonna use the lights, okay? What happens is if you've ever seen it, the baby's gonna be in a little cart like it is. We have this light that moves in and over the bed, but then we actually have extra lights that we can add on. We may have to do what's called a double or triple blink, depending on the level. If the level's really high, we're gonna have to do more than one just thing, okay? So we're gonna put these lights around the baby. This is gonna help break down that bilirubin in the tissue, so that way the baby can then pee and poop it out. Years ago, we used to always start an IV on these babies, okay, because we wanted to help flush it out. But after some more years of study, we realized as long as we were encouraging feeding and baby was peeing and pooping, we didn't always have to start an IV, okay? So that's not an initial thing anymore. As long as baby's peeing and pooping and is awake enough to want to eat, then we're not going to have to do an IV. If you have a more severe baby where that level's pretty high and it's really lethargic, not wanting to interact and eat, sleep, you may have to do an IV to help move that billy faster. We want to make sure that we're checking the eyes, okay? So we're going to fully expose this baby except for the diaper. We're going to leave the diaper on, and then we're going to have a little pair of sunglasses that Velcro around baby's eyes for soft, because we're protecting the baby from the UV light. Whenever we get baby up to speed or change the diaper, we want to remove that mask and assess the eyes. The nurse, as a nurse, you're going to do the temperature every 2 hours, because again, they're uncovered, but under that light does create some heat. And we usually I made some things called billy blankets that go over the bank of lights. And so they're reusable. We just wash them. But sometimes we go through them really fast because I only have 3 right now that I have made. So we'll have to use a sheet. Okay. And so, but we kind of enclose that around. So therefore it keeps that heat in around baby. Okay. And plus two, that blue light's just not spread across the whole room with mom and dad being in there. Okay. We want to monitor these babies for dehydration. Okay. Because how are we losing fluid? Through the skin. Okay. What happens when you go outside in the sun? You sweat. You have heat or fluid loss through evaporation on your skin. The same thing can happen on the babies, okay? So you have to maintain good hydration. We also do have to be careful of hypo or hyperthermia, okay? Because we don't want to get the baby too hot, but also don't want to get the baby too cold. So we're going to monitor those serum levels every 12 to 24 hours. Usually we're going to do after we get that initial light test. We have this little patch that we put over their forehead so that way it doesn't get exposed to the light, and then we can use it to retest again. Some doctors will have us go ahead and do the light, but then also draw the blood to get the level through the blood count. Newborns with infection. So sepsis can be quick. Okay, if you have a baby that gets sick, sepsis is going to happen fast. And why? They don't have an immune system.
They don't have any, well, that was it.
They don't have the immunity.
Okay, they don't have anything to fight off, but think about the size. They're teeny tiny. Their system is so small compared to ours. Okay, they don't have an immunity, but then their system's so small. So sepsis can happen quick in these babies.
Their heart rate, right? It's like super.
Because their heart rate's faster, it's pumping blood faster through their system. Okay. So infection in the newborn can spread really, really rapidly, regardless of the cause. And it's because their systems are so small and their heart rate's so fast. Okay. So be it GBS or E. coli, these are your most common things. Also, nosocomial infections, which means what?
Hospital.
Hospital-acquired infection. Okay. MRSA, Candida. Okay. That's why we practice good hand washing anytime we come in contact with any patient, no matter who they are. Okay. Their immune system is lacking those antibodies. And sometimes the infection can also be caused by exposure during delivery. So STIs that maybe mom had, or the GBS. That's why we treat mom with an antibiotic in labor. And why do we treat mom?
She's the one.
The baby's gonna go through the vaginal.
But she can pass them.
Yeah.
Yes, we're not treating mom, right? We're not actually giving it to mom for the infection. We're giving her the antibiotic, so it crosses the placenta and is prophylactically treating baby even before it's born. Okay? And we do Pen-G or ampicillin, and they usually need at least 2 doses before they deliver. And it has to be an hour after that second dose before they're considered covered. Okay? If they don't have full coverage, then we're gonna keep baby for 48 hours. We're gonna assess for signs and symptoms of infection, which are what? Fever,
Respiration.
rapid respirations,
High heart rate.
sometimes high, sometimes low. They could have hypotension or hypertension. Okay, so think about an adult. How does an adult present with an illness? Pretty much going to be similar symptoms with a newborn. Okay, so we want to make sure we monitor them for 48 hours, and then and then we're also going to draw a blood culture, and we're going to collect a CBC just so we can verify initially what is our baseline. Okay, we're going to send the blood culture off for growth, and at 48 hours, if we have no growth, we usually will send them home with precautions, and then they definitely need to follow up sooner than later with the physician. Okay. So assessment, we're going to look for those changes. We're also going to have some things we're going to see like with temperature, but we're also going to see lethargy, irritability, hypotonia. Okay. Feeding intolerance, tachycardia, apnea, blood cultures and spinal cultures are possible. So I may do a spinal fluid tap if they have possible signs and symptoms of having something that could go into the spinal fluid. Urine and skin cultures if needed. So our babies here, if they're born outside of the hospital, Dr. Lucero likes for her babies to have skin cultures done. And they have to wait 48 hours to go home. And the reason is we need to make sure they weren't exposed to something that, could be detrimental over time.
Like if they didn't make it to the hospital?
Yeah, so if they deliver in the car in the parking lot, even if they deliver like on the elevator, we're still gonna do skin cultures, just so we can see, because even though vaginal delivery in the hospital room is not completely sterile, it's gonna be more aseptic and clean than it would be in the car or, in your house. Okay. You're possibly gonna have to do antibiotic or antiviral therapies. So they can take a cyclovir, okay? Ampicillin, ceftomax, ceftoaxime, gentamicin, or vancomycin, okay? Remember on your gent and vanco, we're gonna have to do peaks and troughs, okay? Because we've got to make sure we're not getting toxic. Okay, some questions. NRP questions. See how much y'all retain. So a 7-pound, 14-ounce infant was born 2 hours ago to an insulin-dependent diabetic mother. The infant's blood sugar is 47 milligrams per deciliter. What is the priority nursing action? Okay. Recheck the blood sugar in 6 hours. Begin an IV of D10. Feed the baby 1 ounce of formula or document the findings in the chart.
He's a baby. If he's drinking formula, he's breastfeeding.
I think it's D.
Is within normal.
It's within normal limits. Now, I might do some further assessment and see how long ago it was as the baby fed and maybe encourage her to wake baby up in the next hour at least. But it's still within normal limits.
Document.
Now, if it was 40, 41, I would definitely probably encourage her to go ahead and feed baby. But at 47, we're still within normal limits. So we're going to document. Okay. Now, if it was 39 or 40, yes, we're going to encourage her to go ahead and feed. Okay. At 47, we're still high enough that we've got some time before she would definitely have to feed.
So we basically wait until it goes below, like really borderline or.
Yes, borderline or just a little below, but most of the time if you are assessing a baby's feeding like it's supposed to, you're probably not gonna ever see it go below unless there's a secondary issue going on. Okay, so if it's just due to hyperinsulinemia because mom had high blood sugars, as long as it's eating, it's gonna maintain that blood sugar, okay? A neonate needs to be gavage fed, okay? Do we know what gavage fed means? So they're gonna have the tube drop down their mouth, an OG, and they're gonna be fed into the stomach, okay? What is the nurse's action prior to each feeding? Didn't talk about this today, but y'all know about NG tube. Kind of know about what we need to do with an NG tube. Okay, so let's look at this. So prior to feeding, so what we're doing prior to feeding, what are we gonna do? Inject 10 to 15 cc's of air, listening with the stethoscope over the epigastrium for sudden rush of air movements into the stomach.
No.
No. Think about 10 to 15 cc's of air. That's a lot of air for a teeny tiny tummy, right? So that immediately out the door, okay? Aspirate stomach contents with syringe and note amount, color, and consistency.
No.
Let's move on. Place the end of the gavage tube in a glass of water and watch for air bubbles.
No.
Obtain an X-ray verification of correct placement of the tube.
No.
I would say B.
Why?
So on a baby, when we're doing gavage feeding, we are going to assess with a little bit of air, but you're talking like 1 cc to half a cc of air. Okay, and we will be listening for the bubbling. Okay, we do not have to have an X-ray to verify placement as long as we heard our bubbling. Okay, we are going to aspirate the stomach and see how much we get back, what color and consistency it was. Okay. And the reason we're doing this is because we want to make sure that formula is actually being processed through the stomach, okay? We're looking for any indication of having some bowel obstruction, some necrotizing and enterocolitis, all those things we know that could potentially be wrong with those bowels. This is going to tell us, is baby digesting the formula? Could be just related to the formula. Maybe we need to change the type of formula, okay? So we need to aspirate the stomach, see how much we get back. We're going to note the color, amount, and consistency. Then what am I going to do with it? We're going to document it, but what am I going to do with that I pulled out? We're going to put it back. Okay. We don't want to cause any fluid and electrolyte imbalances. We're going to put it back. Okay. Does that make sense?
Yeah.
If it's a lot, am I probably going to go ahead and feed baby? No, I'm probably gonna call the pediatrician, let the pediatrician know, hey, I pulled out 5 cc's of formula and it was still pretty thin. It wasn't really digested and we fed 2 hours ago. Okay. She's probably gonna say, let's reduce the feedings to so many cc's or mLs per 2 to 3 hours. Okay. Because you're probably overfeeding for that baby system. It's not digesting fast enough.
Even on this question, if it's getting to like prior to the feeding, it makes it sound like you would have already verified the placement anyway, so.
Right, exactly. And plus two, the other thing on the placement is the amount. We would never do that much. We would just do 1 cc max. Okay.
There is an instance where you do use X-ray for verification for something.
Yes, there are. If there are times you are going to verify, like the ET tube, if you're having to intubate them and you have the endotracheal tube, you're going to verify placement with that. But with the gavage feeding, that tube is actually going to come right back out. We're not going to leave it in place. We're going to do through the mouth down to the tummy. We're going to feed the baby, and then we're usually going to come right back out with it. Okay. Okay. The nurse in the neonatal intensive care unit receives a telephone call to prepare for the admission of a 43-week gestation newborn with APGAR scores of 1 and 4. In planning care for the admission of the newborn, what is the nurse's highest priority? Okay. So we're getting a baby, post-term, initial APGARs were 1 and 4. Okay, so I'm assuming it hasn't got to 10-minute checks. We don't have a 10-minute one because we would normally have a 10-minute one if we have a 1 and a 4. Okay. So what are we going to do receiving this baby into the NICU? Okay. Turn on the apnea and cardiorespiratory monitors. B, connect the resuscitation bag to the oxygen outlet. C, set up the IV line with D5 and water. Set set the radiant warmer control temperature at 97.6 degrees Fahrenheit. Okay. So a lot of these are correct, right? But which one do you think would be the most correct?
D, I say D.
Good job, Bree. A, B, C, airway. So our initial, the main thing we need to make sure is I'm gonna be able to oxygenate this baby when it gets here. Okay? If I don't have my oxygen connected to the outlet and that baby comes in there and I need to start resuscitating, am I gonna be benefiting that baby any? No. Okay? This is correct. I need to have my monitors on and ready. So that's correct. Okay. I possibly at some point need to have my IV set up, but that's probably not my most important thing at this moment. Okay. And yes, I should have my warmer on. So in what order would you do these?
B,
B,
A, D, C.
BADC.
okay, I would do B, D. Why do I want D? Thermoregulation, okay, because
Right.
this is gonna monitor.
It's not helping, it's just monitoring.
Right, this is just monitoring, okay, it's gonna kind of help me in the long run, but initially I need to make sure my baby has oxygen, that it's staying warm. Okay, ABC, this is somewhat circulation, but I can also auscultate with my stethoscope. Okay, this is a necessary, but it's not the most necessary. So it would be B, D, A, C. Okay, so all of our answers were correct, but we have to decide on what's the most correct, okay? Which neonate is at the highest risk for developing cold stress? A neonate that delivered at 42 weeks and 6 days, a neonate diagnosed with Down syndrome, a neonate that is appropriate for gestational age, or a neonate that has a blood sugar of 50. Okay. A1. It's post-term, right? It's post-term. It's after that 42 weeks. It's probably used some of its glycogen or glycogen stores. Probably burned off some of its brown fat already to help keep it alive, because that placenta may not be perfusing as well. Is this a normal blood sugar?
Yeah.
Yep, so we know that we're not at risk for any issues related to that. An AGA baby, does it have a risk for hypoglycemia?
Appropriate.
It's appropriate unless mom's diabetic, but we don't know that. They didn't tell us that. Okay. Or a neonate diagnosed with Down syndrome. There's nothing there that's going to make it any different than any other baby. Okay. So yes, 42 weeks and 6 days because it's post-term.
So post-term, they lose that brown fat.
Yep, they can.
That's what makes them more successful.
Yes. They lose that adipose. They don't have as much adipose tissue because that brown fat stores are gone. And so it doesn't have that extra glycogen storage in the liver either because it's already used that. Because that placenta most likely is not going to be working as well. Now, there are some babies that are post-term that placenta continues to work well, but they just grow really, really big. Okay. And therefore, they're at risk for hypoglycemia because of that. And then also, they could be at risk for cold stress because they have more surface area because they're bigger babies.
What is it, blood sugar range? 40 to
40 to about 100. You know, it just depends on the last time they ate. So, yes.
On your preemie babies, like how often, like how soon, like average, do they go home, like after?
It just depends. Like, rule of thumb usually is that they stay in the NICU till their due date. That's kind of like pretty much the rule of thumb. Here, so it depends on their weight. So if we have a lady that comes in and delivers at 36 weeks and that baby weighs 4 pounds, 10 ounces, more than likely the pediatrician's going to want that baby to be maintaining its weight and getting closer to 5 pounds before we'll let it go home. Okay. So we're just doing what we call grower feeders. So we're feeding the baby, letting it grow, but it's in a safe environment. So if something happens, we have any distress noted because of being a preemie baby, then we can immediately act. But in a NICU setting, usually most babies stay to their due date or past. Very rarely do they go home prior to that term date. So, yeah, that's kind of just the rule of thumb. And some stay longer, and some do stay a little shorter if they get kind of closer to the term date and they're doing really, really well. So,
At 37 weeks, do you still give them the steroids for their lungs or not?
no, we usually don't do after 36 weeks. So after 36 weeks, we usually do not give betamethasone because we know that they're close enough that their bodies probably could switch over. And remember, our dating is pretty close, but still can be somewhat off, you know. So, but if we're before 36 weeks, we're going to get betamethasone. Another question. Okay. So you have 19 minutes till noon, okay? So this is the plan for this afternoon. I uploaded an assignment that was gonna be a group assignment for later today. I'm gonna take it down, because again, like I said, I do not want us to gather in groups at this time to help reduce any more exposure. Please be cautious when you're home. I know your kids go to school, they're exposed, your husbands, significant others, wives are at work, girlfriends, whoever, boyfriends. Please though, just make sure you're doing good hand hygiene at home, okay? Because I just want to keep you guys well, because any amount of time you miss, you know, yeah, we can zoom in and stuff, but you still miss out on some of the stuff, okay? So like I said, we're not going to do any group projects. So most of you have kind of like your group stuff we worked for Friday together.
Yeah, I think so.
Okay, so, so this afternoon, unless you need to meet with a few members of your group, then I'm gonna let you do your work at home this afternoon, because like I said, I want to reduce our amount of time together, in close proximity for this week and part of next week, okay? Just so that way we can keep everybody healthy, because we're about to start clinicals. And so if you're having to be out because of COVID, those are hours we're gonna have to make up later on in the semester, and I don't want to run out of time. Okay, so you know, I can do a certain amount of time with some case studies and things like that, but you have to have so much percent face to face. Okay, and so we're about to start clinicals, and I don't want you to miss out on clinicals because you're sick. Okay, so we're going to be proactive in the classroom this week and next week to try to avoid any more illness. Okay. If you have questions as you're going through stuff later today, just send me a text, send me an email, call me on the cell phone, call me in my office, okay? I'll answer any questions, okay? I looked up some videos last night for your, so on your ATI, you do have some dosage calculation practice things I'm gonna open, but it is dimensional analysis. So if you're not really good at dimensional analysis and you wanna know other way of doing it like I do it, I have some videos and some links that I found that I'm gonna kind of create a little help thing module to post up on my classroom that you can look at. Okay. Okay, good. Janessa Marker's good. But I know all the ATI stuff is kind of dimensional analysis, and not everybody does well with that. And I understand that's okay, because I don't either. Other people can't do it my way. They'd rather do it dimensional analysis way. So, and that's fine. So whatever way works best for you, because there's really no wrong or right way. As long as we all come up with the same answer, we're good. Okay. Any other questions?
At the bookstore, they have the cap and gown order stuff. Do we need to fill that out or?
Yes. So you will walk as a like diploma receiving student. Oh wait, no. Just remember, last week, Susan had asked if we could do our graduation with our capping and gowning, and as of right now, they have agreed to let us do so. So that means you guys will not have to come back on Saturday and do the actual walking graduation with the rest of the college. You will get your, like you can wear your cords and things at graduation or at capping and pinning. Okay, so you won't actually have to go to the actual graduation the next day.
Do they have it like it's due the 21st?
Right, so you do not need a cap and gown this year. Okay, I can't say that next year in level 2 that they'll change it and you have to walk, but as of this year, they have already agreed to let you guys just do the graduation part with our capping and pinning. So you can wear your cords with your white scrubs, okay, if you're with honors. And they do have some med search books. So if you were waiting on med search books, they have the med search book and the study guide that goes with it, okay? The study guide's just good, it has tons of NCLEX style questions in it. It's just really good to review when you're practicing for the test, okay? Because always remember, just like today, we had a question pop up and we really didn't, I had actually pulled that content from the lecture with the gavage meetings, okay? You may have something pop up on your NCLEX that we haven't had gone over, because there's so much content in nursing that I can't give you every single detail about every single thing. So that's why you should start practicing those NCLEX style questions now. Get you a book that has an app that goes with it that you can get on there and practice certain systems, you know? And it's because there's some things you will have to learn on your own, okay? I can try to feed you as much as I can, but unless you want to be here 7 days a week, 24 hours a day for the next 2 years. I don't, sorry guys, I really love you, but I want to see my family. Then, you know, there's some things that you're just gonna have to kind of learn on your own, okay? And so that's why those NCLEX style questions are good to just go over and practice. Because something may pop up that you're like, I have no idea, but then you gotta kind of think through it. Because y'all did with the garage meeting, you thought through it, right? Like Rita said, we know this, and we know this, you know, you can look at the answers and see, okay, well, that's silly, why would we push 10 to 15? Okay, and then go on to the next answer. And you can probably narrow it down to the correct answer, even if you don't know exactly what your content is being given to you. Okay. Okay. So we will meet back tomorrow at 8:30 in the morning. Tomorrow afternoon, I'm going to talk to Suzanne, just let her know what the plan is. Because these are extra hours in the afternoon, it was some simulation time, but we're going to have a few extra simulation hours that we can kind of deplete a few this week and it'd be okay. Okay. We have a little bit of buffer, and I did that on purpose, 1 for snow, but 2 for situations like this. Okay. So probably today and tomorrow we'll plan on not doing afternoon. Friday, we probably will do afternoon as long as you do presentation. Yes. Yeah, I'll do yesterday and I'll do today. And then I posted yesterday's Zoom. I will post today's Zoom instead of the old one.
It's not linking. I tried to go and link it and I can't. I have to go straight into the YouTube. It's saying error or something.
Oh, yeah, you have to, so the YouTube link's not working? Okay, I don't know why. I'll figure it out.
We have to have a study guide for the Friday's presentation, right?
Yes, so someone did ask, if you create a PowerPoint or you create a brochure, you can use that for your study guide, okay? If you are doing like a skit or a presentation that doesn't have a PowerPoint or a brochure with it, I want you to create a short study guide for your friends, okay?
How many questions does it matter?
Doesn't matter, just as long as you're covering the content on there, it doesn't matter how long it has to be. Okay, sound good? See you tomorrow. I'll let you go 10 minutes early.
Because I tried to watch the one from last.
Oh, yeah, sometimes it does that, and you have to hit that little arrow.
Oh, okay.
Yeah, if you hit that little arrow, then it'll take you to the YouTube, just like that.
I just went straight into the YouTube because
Right,
I didn't know until yesterday. Up until yesterday, I didn't plan on just going to YouTube.
right, yeah. And find my channel.
Yeah.
I have a YouTube channel. Okay, guys, Steph, Marisol, do y'all have any questions?
I do need clarification. So the pediatric assessment assignment for today, we're not doing. Okay, and then for the other one, do I have to do I do the essay and then a PowerPoint and brochure?
Yes, so just because you're not gonna be presenting it to the class, I just want you to kind of just do a quick essay of like what information you feel is most important that, you know, you need to point out. It doesn't have to be super long, but just since you're not doing the presentation part, if you'll just do that for me.
Okay, and then what are the age groups?
So it's infant, which is 0 to 1 month. Then the older infant, which is up to a year, 1 to 2, 2 to 3, and then you have 4 to 5, and I'll send you the list. Because I broke it up into like 6 different areas. So, and the teen is broke up more than what the book breaks it up, but I wanted you to think about like 12 versus 17. But I'll send you the list that I made, and then you can just choose whichever age group you want to do.
Okay, sounds good. Thank you.
You're welcome.
Miss Amanda,
Yes, ma'am.
for my group, I had the PowerPoint and I already emailed it to everybody that was in my group. But do I have to do like one like Marisol's doing?
Yeah, just if you'll do just like a quick little essay presentation, so just type out like what you would present and based upon your PowerPoint and just send that to me, then that will count as your presentation point.
So an essay over the PowerPoint that we've
Over the
already done.
content, yep, and that will count as your presentation point.
How many pages do you want it to be?
If it's less than 1, that's fine. Just as long
Okay.
as you tell me what the content is, what's important. I'm not gonna give you a number. You just tell me what's important to know about this age group.
Okay, thank you.
You're welcome. Okay. Bye, Steph. Hope you get feeling better.
Thank you.
Yes.
So for us, with study guide,